I'm very much
We're now live. It's in my. We just give them.
Good morning, everybody. I hope everybody is well. I've got an echo, slight echo, I think. Just want to check. Colleagues that are online and on Teams, can you hear and see us okay? Good. Thank you. So, keen to start on time and finish on time, so apologies for being 2 minutes late. For those that don't know me, I'm Simon Whitehouse. I'm co-chair of the Health and Wellbeing Board across Shropshire with Councillor Motley, who's on Teams this morning. So hi, Councillor Motley. My turn to chair this meeting. I'm obliged to inform you the meeting's been live streamed. So we are being live streamed now, so we're open to the public and people can see the meeting and hear the audio. I'm really just going to go around the room first for introductions, and then I'll come to those colleagues who have joined us online, and then we'll get into the meeting proper. So I'm going to come this way. Rach.
Thank you. I'm Rachel Robinson, Executive Director of Health, Wellbeing and Prevention for Shropshire.
I'm Carl Binkley, Associate Director for Strategy and Partnerships at SAF.
Nigel Lee, good morning. I'm the Director of Strategy and Partnerships at SAF.
Good morning, Tanya Marr, the Director for People at Shropshire Council.
Morning, Stuart Bill, Superintendent from West Mercia Police.
Hello, I'm David Crosby, Chief Officer for Shropshire Parks and Care.
And Michelle Dulson, Committee Officer for Shropshire Council.
Laura Tyler, Assistant Director for Joint Commissioning.
Morning, Paula Mawson, Assistant Director for Healthy Population at Shropshire Council.
Good morning, I'm Melanie Franks. I am the Public Health Principal leading on integration.
Morning, Penny Mason. I'm Head of Joint Service for Shropshire, Telford and Wrekin NHS and Shropshire Council, sitting in Public Health.
Hi, I'm Jackie Jeffrey. I'm Chief Officer of SIDS of Shropshire, and I'm here representing the Voluntary Community Sector Assembly.
Good morning, I'm Lynn Corley, Chief Officer at Health Watch Shropshire.
Morning, everyone. I'm Val Cross. I'm the Health and Wellbeing Strategic Manager at Shropshire Council.
I'm going to come to those on Teams, if that's okay. So, Councillor Motley, I'll come to you first, if that's okay. Yeah, you're on mute, Councillor.
Sorry, it's a bit early in the morning for me, obviously. Good morning, everybody. I'm Councillor Cecilia Motley. I am the portfolio holder for Adult Social Care, Public Health and Communities for Shropshire Council, and I'm also co-chair of the Health and Wellbeing Board. And I'm sorry that I'm not with you this morning.
Thank you, Councillor. Councillor Hurst-Knight.
Good morning. Apologies as well. I can't be with you. Injury. Councillor Kirsty Hurst-Knight, portfolio holder for Children and Education, Shropshire Council.
Thank you. Ben.
Good morning. Ben Hollands. I work at MPFT. I'm the Health and Wellbeing Strategy Implementation Manager there.
That's fine. Jess.
Good morning. Jess Edwards, Public Health Intelligence Analyst, sitting within Public Health at Shropshire Council.
Thank you. Have I missed anyone, Michelle, online? No. Right, okay. Okay, so morning, everybody. Packed agenda, lots to get through. Really keen that we get into the discussions into the right parts, and I'll go through the agenda shortly. In terms of apologies, had apologies from Patricia Davis in terms of Shropshire Community Health, but I think she might well join us online for the Better Care Fund aspect of the agenda. Also had apologies from Sarah Ellis, from Robert Jones and Agnes Hunt Orthopaedic Hospital, and then equally Claire Parker will be joining the meeting later on online as well. So, have I missed anybody's apologies or not covered anything for anybody? No? Good. So, disclosable pecuniary interest, agenda item number 2. Reminder to colleagues and to members to make sure that we've disclosed any pecuniary interest relating to any matters discussed which is not included on the register of interests, and make sure that we leave the meeting prior to being discussed. So hopefully we've got everything recorded, but if there's anything that is a conflict or anything else that needs to be declared, please do that as we go through the meeting so that we can manage that appropriately. Okay, so then minutes of the last meeting. Assuming people have read the minutes, just want to check from an accuracy point of view that people are comfortable. Lynn.
I just wanted to say that I think I was actually in the room last time. It says I was virtual, but I distinctly remember speaking to you. So I was in the room.
And I was virtual. So we'll get that corrected. Anything else on the minutes in terms of accuracy? No. Good. So in terms of the actions that were in the minutes, and as ever, Michelle, colleagues, and Val, thank you very much for the work in terms of capturing the meeting and making sure that we've got an accurate record going forwards. There was a number of actions. First one was about Executive Director for People. So Tanya had asked for a detailed update on the Oswestry Test and Learn site. That's on the agenda today, so we'll pick that up at that point. There was a recommendation from the BCF paper that a further paper be brought back in terms of the funding against hospital discharge. It's been noted as being on the forward plan. Have we got a plan for that in terms of, I think that needs to be June. I think.
Yeah, I can put that on the forward plan.
If that's okay.
Yeah.
Please. There was a recommendation in terms of the air quality report that further reports be brought back and presented to the board, and again an update planned for the June meeting. There was a recommendation from the Shropshire Drug and Alcohol Strategy to receive a further progress report. That's on the forward plan for September. Health Watch Shropshire's forward plan for 23-24. Lynn, you'd asked that if anybody got thoughts in terms of any of the areas of focus of work they could undertake, to contact you. Just want to remind colleagues that you can do that, and then you can take that into the Health Watch board. So a further prompt to be having those conversations. Vaping children and young people and the concern of the board. This work continues to progress with the Task and Finish group being led by Public Health. Thank you for colleagues working on that. There's a briefing paper for schools and for those working with young people, and that's been circulated following final sign-off. And then again, forward plan for June, that will come back and there'll be an update to the June Health and Wellbeing board. I think on that basis, I've captured the actions and the updates that go with that. If colleagues are okay with that, I would propose that the minutes of the Health and Wellbeing Board held on the 19th of January, as circulated with the agenda papers, are signed as a correct record. And if somebody could second that, please. Second is by Tanya. Thank you for that. And I will sign the minutes on that basis. Thank you for that. Good. Okay, public questions. There were public questions submitted. We've got responses for those public questions. They are lengthy and detailed, and we will publish the questions in full with the comprehensive responses on the Health and Wellbeing Board website by at the latest the start of next week. Our intention is to do it this week, but I just want to make sure that we get those up and published on the website, so those will be available for everybody to see in terms of those responses. Okay, for those very observant of you who study the Health and Wellbeing Board agenda on a regular basis, you'll notice that we've changed the structure of the agenda slightly. So myself and Councillor Motley with Rachel and Val had the conversation in terms of how do we make sure we get the time on the agenda to have the conversation about the areas that actually we get the biggest value from the input of Health and Wellbeing Board members, to make sure that we're focusing on the right priority areas. So what we've looked to do with the agenda is break out those areas that are the strategic items for discussion and for conversation, and we'll spend longer on those on the agenda. Separate those out from the reports that come here that require the approval of the board but don't necessarily need the same level of conversation and discussion. The expectation is for colleagues presenting those papers will have been read by board members, and we'll move through those relatively quickly. And those equally reports that are for information, where there won't be a conversation or discussion about them, but they will be noted and will be seen about that. It's really about making best use of our time and how do we make sure we have the right conversations about the right areas. It's a bit of a trial and error. but let's work with it and see where we get to, and we'll finesse it and evolve it as we go forward, I think. But hopefully that makes sense to colleagues and people can understand why we try to move the agenda around in that way. And we'll keep doing that and setting that out so that people can see where are the areas for discussion and where those areas then are where it's approval. The bit then when colleagues are writing papers is really thinking about how do we get the right agenda items in the right part of the agenda so that we get the right conversation about them. But I'm going to move us on then if that's okay, because I think hopefully that makes sense and people are okay with that. So I'm going to move on to the Healthy Life Trauma Informed Approach, and I'm going to ask Val to take this piece.
Thank you, Chair. I've submitted a paper about the trauma informed approach. I'm going to assume everybody has read it, and I'm not going to go into detail, but this is a summary of what is in that report. And just wants to start about what trauma and adverse childhood experiences are. You can see in the graphic there the types of things that can affect children in young childhood. So we've got maltreatment, adult responsibilities adjustment, verbal abuse, physical abuse, mental illness and separation. And these ACEs, adverse childhood experiences, or ACEs, refer to some of the most intensive and frequently occurring sources of stress that children may suffer in early life. There's a quote here from Van der Kolk, The Body Keeps the Score. This is an excellent book, but something that is quite hard-hitting, so it's not bedtime reading, it's a dip in. And he describes it as a constant sense of danger and helplessness promotes the continuous secretion of stress hormones, which wreaks havoc with the immune system and the function of the body's organs. And I'm just going to give you some information about the effects. People often think it's a mental health, but this has a real physical effect on people's bodies, and this is really important when we talk about our health systems and our care systems, that awareness. And it's costly in both human and economic terms, but the real impact is on people. This is a human approach, this is a human condition, and that is where the effect is. So you can see some I've updated this from the paper, the information. It's the same, but the references are here, and I know that Michelle can circulate this presentation afterwards and publish it. So quite hard hitting. So this was a study that showed with people compared with no ACEs. So going back to that graphic before, those different examples of ACEs, 18 to 16-year-olds, twice as likely to develop cancer, 4 times more likely to develop type 2 diabetes, and you can see the rest that talk about respiratory disease and also drug use as well. In terms of healthcare use, another study found that those with more than 4 ACEs compared to those with those continued, and there was higher healthcare use through that age group. Again, mental health, Welsh study, 6 times more likely to suffer from mental illness. And also there was some research done into emergency department and overnight stays. So 0.9% to versus 25% of people who have more ACEs. And I've just starred those because these are the ones I've starred are priorities of the ICS Joint Forward Plan, those clinical priorities. So I just really want to stress that element of that physical health. And, at the end of the day, we talk about this as a human approach. It's going to affect all the work that we're doing, people who've been affected. So this is examples of national practice, and in a school, 107, this is an example, they had ACE training initiatives, and they found that their lost days due to pupil exclusions went down from 175 days to 75 days lost. Prisoners and their families, this is a really interesting case study of how the prison involved families of prisoners with the ACEs, involved prisoners' families, and so they would have parents' evenings at the school where the teachers would be there to talk to the prisoners with their families and the child about the progress they were making, and it really is. I've put the link there. It's well worth having a read of that because it's very interesting, and you would celebrate the achievements of those children of the prisoners of those children of those prisoners, no matter what their achievement was, it was all about building that celebration of that family relation, the child and the family. So you'll see there about, with this intervention, the employment rate for prisoners coming out of prison, the reduction there, the increase to 80% from 25%. And again, because of time, I'm not going to go out there in detail, but again, children considered by social services to be at risk went from 16 to 7%. And again, in speaking to young people in custody, there's an intervention there, and they have custody intervention rates, and it talks there about the rearrest rate from people who've gone through the programme. So moving on. Okay. This just is how trauma informed connects to local plans. Not going to read them out, but you can see all our partners here. There will be something that links in there, from your Armed Forces Covenant right down to our ICS plans and the Shropshire plan. Okay. So this trauma informed approach, it's about, it can be very simple things that start. It is a culture change, and we know the system's complex, but I'll just come back to, this is about being human, and trauma-informed approach isn't just for people we work with, it's us as employees as well, because it makes no assumptions about what experiences that people have had. So again, I keep saying I'm not going to read through it, but these are just examples. The top two are examples of, it's very much about preventing, helping to prevent ISIS and trauma can have a single trusted adult in a person's life. So in childhood, we've got an example of a relationship with a teacher that was really good and building that self-esteem and confidence. Also, seeing lots of different people, not wanting to repeat your story. And also environment, going to a clinic that can be busy, it can be grim, let's face it, some places are. And also the last one about official looking letters. We can send a letter out and that can immediately trigger people if it's complex and people start to get anxious about what's in there. And we talk about, people not attending appointments. We need to really think about why they're not attending, what's happening there that's not helping, rather than getting frustrated. But what's important is there is always hope, and poor outcomes with high ACEs aren't inevitable. So it's important not to label people as such. And we've talked about that safe, stable, nurturing child relationships, encouraging that, and we can minimise that in things that we do. So being trauma-informed, so from what's wrong with you to what happened to you. And these are just examples of simple things that can make a difference. Listening, person-centred, so people aren't, it's not the disease or the behaviour or the issue, it's about that person-centred approach, building trust, written language, environment, and most importantly, kindness and understanding. And what I'm not saying with this presentation is that we're not doing this. We do our jobs because we care about people, we want to make a difference. People will be doing this in their jobs. They might not be aware of it, but we do know it isn't happening in some services. So a consistency approach is absolutely critical to make this work. Sorry, man. It's not moving on. Come on. And is it nice to have all part of our fundamental human rights? Scotland and Wales, this is part of their government. They have trauma in practice. Their governments say this is what we need. And locally we have, Shropshire's very passionate about it. And we also have other areas, trauma-informed Manchester, they want to be a trauma-informed city by 2025, I think it is, or 2029. And other areas are doing this as well. We can see Shropshire and Telford and Wrekin. We are working with our colleagues at Telford and Wrekin. We're aware that ICS is a Shropshire, Telford and Wrekin system, and we want to, bring us all together. We have seen a film, some of you hopefully have seen it, called Biology, the Stress and Science of Hope. And we've had the facilitated workshops, and over 700 staff have seen this before, and I'm going to come on to their comments. And we have got a multi-agency trauma-informed group, which Kirsty Hurst-Knight, who's there, is our great chair for that. I think this is important. This is what we want is a system approach to trauma-informed, and this is what staff are saying who've been on this. So, got to be a system-wide approach. Impact of trauma on our physical health is so obvious but not spoken about, recognised when supporting people. What are we doing about it? Why are we waiting? It's not just naughty kids. It will stay with me forever, this film. So what we'd like to do, our trauma-informed steering group, these are what we'd like to do for our next steps. Focus on early years and primary education on a miscandra approach. Basically, this is those of you who haven't seen the film. This is an approach about giving constant messages to children. Children have a right not to be hit. And we start this from very young, different messages, and miscandra writes back. And we're piloting this with future in mind. And we've got 6 primary schools and a secondary school who want to pilot this with us, and we can see how it works. It was really exciting. I think it's going to be fantastic. Production of a simple resource. So people about trauma and what approaches you can do. Continued work to develop a training offer. We've mapped what training offers are out there, and it's obvious that there's some really good training offers out there, but it's not consistent. So that means somebody coming into a service might have a really well-informed, trauma-informed, they have the training, they're using the approach. They might go to the next place, and that's not in place. So again, we need to think about these people not attending, people withdrawing. I've heard it services being described as the inconsistent parent, that inconsistent parent. So we as a system need to be that consistent parent, if you like. So we think you can see the tiers, those 3 tiers we would like to have, but have it mandatory for anyone. And this is anybody from, not because receptionist is a low level, from a receptionist, and talk about people we work with, who we come in contact with, right up to our top senior managers, being trauma aware. But it's really important for staff as well, and I can't say that enough. We need to look after our staff too, and we have great offers on our websites and things, but I'd argue you have to be in a place to want to access that. Whereas if you've got a culture of being trauma informed, staff are going to be able to feel that. And we know that there's some great practice. I do want to stress that. We know there's some really good practice going on in our organisations, and I'm not saying it's not happening. It's that consistency. So support, we always put that in. That's good practice. We don't know the experiences in this room or the people listening in, and it's really important that we acknowledge people might need to have somebody to talk to. I just want to say thank you.
Thank you, Val and colleagues, for this. So let's open this for conversation. And I was going to come to you. Somebody could we take this screen down?
Yes, I'm sorry. Yeah, sorry. We've got our visitors around.
Right, so Kirsty, I was going to come to you anyway, but you beat me to it because you already put your hand up, which is fantastic. So Kirsty.
Yeah, as Val said earlier, I chair the group, and from a small idea, it was not only seeing the film, Val, but there was some information that came to me, and as a veteran, I was shocked at the brain activity in a child that's experienced this trauma is the same as a soldier that experiences severe PTSD. And immediately after these sort of statistics and facts, we knew we had to do something. And I just wondered if it was acceptable with you, Chair, that we actually say a formal thanks to Val and have it put on the record, please, that, these things don't just happen. Her driving force and her commitment to getting this to, all the research that we've done. Our little group started, what was it, Val, 5 of us? Yeah. I mean, now it's grown as 40, 50 members. As you said, in every area of work, people are now aware of this. And we're not all saying we're professionals, but I had it personally this week. I could speak to a family and I had that understanding of a family and the trauma that this child had experienced. And, that was really, really beneficial to me. So, thank you, Val. And from Penny, Holly, Sean, Anne-Marie, Wendy, Naomi, I'll probably miss somebody, from this very small idea of let's look at what we can do to what you've just presented in the report. I just want to say thank you, Val, and we will keep going, we will keep fighting the fight, and there is some really good stuff going on, but we're now bringing it all together. And I think the idea of what we've got, the levels of training and the offer, it's quite exciting, and it will certainly benefit residents and families of Shropshire. So big thank you to Val. Thank you.
Thank you.
Thank you for that, Councillor. And so I would echo that thanks. And you could, I'm not sure if you could see whilst you were speaking, but the nods around the room, absolutely, we need to make sure that it's minuted and recorded in terms of that recognition and that thanks. So thank you for that. Tanya.
Thank you very much, Chair. So again, to say thank you to Val for the passion and drive in this area, because without your passion and drive, we wouldn't be where we are today. And I think as a Shropshire Health and Wellbeing Board, we're really proud of the work today on trauma-informed approach. I fully support the recommendations set out in this paper, Chair. I'm interested, we've kind of trained 700 staff, I think I saw on that slide. What's the next step, Val, in terms of training for 23-24 in terms of staff of this system? And you also made reference about needing commitment from system leaders. I thought we had that, so just interested about where you think we've not got that and what else we need to do as a system to give you that commitment, give us the commitment that we've got this.
Yeah, thanks, Tanya. Thank you for your kind words. In terms of the 700 plus people, yeah, it's more than that now actually who's seen the film. We're going to continue that, and that's more, rather than training, that's more of an introduction to getting people aware of what trauma and ACEs are. The next step really is to have some sort of training offer in place. So we talked about those 3 levels, but we're aware that to do that, if it's a system, it's about funds and people being, I heard brave a lot the other week in a meeting I was at, and I think it's being brave and saying we're going to commit as a system to, at the first stage, I guess, to, if it was costed out, how much it's going to be, because I've already got contacts. This has been a development stage about contacting trauma providers who provide the training. The first step, I think, is to have this online resource, which we can do in-house in terms of training, that we can have everybody to have as part of their compulsory induction training, or even a yearly one like we have with our data and all things like that, those exciting ones. You know, I think that would be the first step would be, to recap, would be getting it online in place. I think that could be done fairly quickly. And then the next step will be costing up how much it will be to do the training. And then the other, your other question, which I've just forgotten, what was your
system leadership? Senior leadership.
Yes, thank you. Yeah, we have got that senior leadership, but that I think there's still, I'd argue there's still perhaps we still need to push that a little bit more across the system, because I'm not sure that everybody still gets it, with respect, because you know that everybody still gets it, and so I think it's important everybody at the top level sees the film. If they haven't seen it, that they need to see it, so they have that basic understanding at least. And we could even do a bespoke one. We can arrange that. That's fine. Our cabinet has seen the film and have been very enthusiastic about the approach. So we know from that level it's there. And then it would then need that leadership, that brave leadership. So yeah, we're doing that and we're going to invest in it.
Penny, and then Lynn.
Thanks, and of course, thank you, Val. You've done amazing work. And there have been difficult times with it, because it has, I would just being really honest, I think it has felt that there at times, I think that has shifted, but that there hasn't been that kind of whole system leadership buy into it. But I think that has shifted. I think the reason why that's continued to be requested as a priority is that it's partly investment. So there's elements. So we had a really, Val talked about some case studies and research we've done elsewhere, but we've heard some fantastic stories here in Shropshire. So we have, and I may have talked about it last time, but it was so kind of powerful to me that we had a physiotherapist from our community trust working with a young person who'd gone through an operation that same physiotherapist had gone through as a child. And so the physiotherapist was able to recognise the trauma that child had gone through and the child just stopped doing the exercises that she needed to do to get better. And the physiotherapist knew that child didn't need more of somebody telling her what to do, but needed somebody to listen. So she spent a whole session just listening. And the feedback from the clinicians following that was, actually, that child has turned a corner. That child is doing what she needs to do. That child is really making a difference in her own life and is going to get better. And that was because that physiotherapist took that time to listen. But the other side of that is that physiotherapist also needed somebody to talk to about that situation, but also about what happened to her in her childhood. And so there's an element of this around the TRIM, which we do use in the system. So that's around our trauma package for our own staff, and we'll know across all our emergency services and all of our services that we see a lot of trauma and then have to kind of internalize that and figure that out ourselves. We know the fire service have a really good model, TRIM model, that when they've seen something or been to an incident that is traumatic, that they get that TRIM session immediately. So there's something about us recognizing that we've got our staff know how to support people in this way right from the off, and it's very person-centered. So it comes back to personalised care in the NHS. It's right there, but that our staff are also supported to do that, and there is an element of investment with that, and I think that is where we're not there yet. So just being really open and honest about that.
That's helpful. And Val and Penny kindly brought this to the ICB team huddle. So we had 142 staff online on Tuesday morning, and we dedicated the entirety of the huddle to this, and it generated significant amounts of conversation in the chat and in the call. So it was great. But my other thought then, in terms of an additional recommendation, is I think the animation, the video piece should come. We have resident stories at the start of every of the integrated care system boards, and so we should use this as one of the resident stories. So if we can plan that for a future board, because then that will get to all chief execs and chairs and leaders and portfolio holders. People will have seen it. People can see it twice. I think that's absolutely fine. So I give my commitment to take that to the board. Lynn.
Thank you. Now, as Chief Officer of the Health Workshop, you might wonder why Lynn's got anything to say about this, but this is something I'm very interested in as an ex-teacher and as an ex-social worker, certainly having worked with young people for whom their previous trauma has directly impacted on their ability to stay within education and achieve their ambitions. But I suppose the thing that I just wanted to talk about was what I think it's right to focus on children and young people. I think it's also then going to be important to make this very much about an all-age piece of work, because we have got a large part of our population who have had very traumatic histories just because of the period of time in which they were born and which they grew up. And I do think that particularly impacts on their experiences of dementia, for example, when those memories come back to the fore. So I think that there needs to be done about more training generally across the system. And I also think, from my own reading about trauma, that there needs to be greater investment in EMDR, which is a specific therapy for people with trauma. Because at the moment, I think it's very limited to people who may have been experienced violence or been through trauma, through war, or for example. But I think adverse childhood experiences need to be more broadly recognised in terms of access to EMDR in Shropshire. The other thing I think is that there's a lot of work to be done about understanding the links between trauma and the similarity between some of those symptoms and autism and ASD. So I think there's a lot of work that we still need to do to understand that. And it was my understanding that this system was not continuing to invest in TRIM. So I'm sorry if I've got that wrong, but I think that might be something that's worth looking back at again, because I was told that we're not focusing on that anymore. So I just think there's an ongoing conversation around these issues.
Nigel, then I'm going to move us on to the page.
Thank you. And just to reinforce the support is so important. Two quick things, I suppose. The first one, just to perhaps respond to Lynn. So certainly within SATH, we're using TRIM, for a range of different, environments. And I think it links to what Penny was just saying. It's, quite important for certain scenarios. I suppose it was just picking up from probably Tanya's question and then your response, Val, on the next steps. And clearly it's important to do the appropriate thing for Shropshire Council and Shropshire. But what's the opportunity for joining together with Telford and Wrekin for whether that's training resources or looking at online, setting stuff up? Simon's just mentioned the ICB. There's a lot that we're looking at not duplicating if it's not appropriate to do so.
That is a really good point. And just to Lynn, this is definitely an all-age approach. I just sort of want to sort of reiterate that. We we are joining with Telford and Wrekin Council. Lynn Spanian, who's at Telford and Wrekin, we have been linking with her, and although she couldn't be at the presentation, the huddle on Tuesday, she was going to be part of that. She just couldn't make it because that came before with the ICS being Shropshire Telford and Wrekin system. We recognise it's really important that we make this system a whole system approach for those two areas, because obviously we've got South and we've got the across both. Exactly. So when I say the system, I'm talking about the Shropshire Telford and Wrekin system.
Thank you, Rachel.
And I'm obviously going to say a huge thank you to Val for driving us forward, and as Elizabeth said, her passion. I think it's just, as I'm listening around the room, and the huge amount of work that's been done, and the way that we've, as we've outlined in the report, this agenda's moved forward. But I think the conversation and the point that Tanya's raised, and you've talked about around that investment, and is absolutely critical to this. And I know the last recommendation talks about working with the system and commissioners to determine how we embed this. I think we need to be stronger in that. I think we need that stronger commitment. And when I say investment, it is people, as well as, we're not just always talking about capital, but this is an example of where we are we're getting a momentum here, it feels, and we don't want to lose that. But we need more and more people to come with us, and we do need to look at the resources and outline that. So I wonder whether we need to strengthen that recommendation, come back to the board with a really clear plan, and because this is one of many issues where we all members of the board, which is why it's at the board, need to look at investing and resourcing, and we need to start thinking how we do that differently and jointly. Whilst we often pick up these issues, individual organisations apart, because we want to keep the momentum, and we recognise that it's really that absolute commitment, that investment and that resources. So I wonder whether I could maybe suggest that we strengthen that recommendation, ensure that we bring that back with a clear resource plan and clear commitment from partners about how we will resource that going forward in its widest sense.
So I think that's really helpful, Rachel, because I was going to pick up on that anyway. So in terms of the recommendations, the board has asked to support the recommendation to make workforce trauma-informed in principle, that the focus on early years of primary education, working with partners to develop the support for a Miss Kendra approach in early years of primary school, where children feel valued and safe. Production of a simple resource that provides the how-to information for different parts of the system, with key trauma-informed messages and tips. Continued work to develop consistent training offer for the system, including evidence of implementation. So that's the induction tier, awareness and universal tier, advanced and specialist tier. And I think it's this last then recommendation where you're saying we would want to strengthen that from work with system leadership and commissioners to bring back to the board a proposal in terms of next steps and how this gets developed and the commitment required. And then, of course, I also want to add and take and use as a resident story for the integrated care board as well. So with the addition and the strengthening of that final action, then are board members happy to approve the report and sign off the recommendations as proposed?
Yeah.
Good. Thank you for that.
Thank you,
Val. Thank you, Kirsten. Good. Okay. I'm hoping that in the background behind me, subtly, without anybody realising, including myself, because this will fall flat if I'm about to introduce Darryl and Kate, and Darryl and Kate aren't here. But next agenda item is dentistry, and there are indeed two colleagues waiting there.
Morning.
Good morning. Morning. So Darryl, Kate, firstly, welcome to the Health and Wellbeing Board. I'm Simon Whitehouse. I'm co-chair with Councillor Motley of the Health and Wellbeing Board, but I'm Chief Exec of NHS Shropshire, Telford and Wrekin. We've done introductions. I wasn't intending to go around the table again, if that's okay, but we'll leave you to do your introductions. We've got 15, 20 minutes in terms of this agenda item. The paper's detailed. Please work on the principle that people have read the paper and taken the time to go through that. So opportunity to pull out some key points. I'm really keen to get into a conversation about this, given the changes around this, given the challenges that we've got, given the issues of dentistry and rurality and the focus on that's pulled out in the paper. So really great that you're here. Thank you for taking the time to come and talk to us. I'm going to hand over to you and then we'll pick up the conversation after, if that's okay.
Well, good morning. I'm Kate Taylor-Wheatley.
You need to press your buttons on the microphone so it goes red. Sorry.
Thank you. I'm Kate Taylor-Wheatley. I'm a consultant in dental public health. I work for NHS England, and my remit is across Shropshire, Staffordshire, Telford and Stoke-on-Trent. And I work closely with Darryl as the lead commissioner, but also with the local authorities by chairing the oral health network across both local authorities in this area, as well as Staffordshire and Stoke-on-Trent.
Thank you. And I'm Darryl Jackson. I'm the Senior Commissioning Manager with NHS England, but since delegation on the 1st of April, I am working on behalf of the 6 ICBs of the West Midlands. And my responsibility is the Lead Commissioner for Dental Pharmacy and Ophthalmic Services across Staffordshire and Shropshire.
I was going to say over to you, but I should have perhaps done the slight introduction bit, and it does get picked up in the paper and you'll talk about it, I'm sure, as well. So the important point here from the NHS perspective and from the Commissioner's perspective is the West Midlands ICB, so ourselves, Staffs and Stoke-on-Trent, Black Country, Coventry and Warwick and Birmingham, Hereford and Worcester have agreed that as part of the delegation approach, we'll look to work collaboratively so that we don't split up resource and fragment things. So we'll be sensible and collaborative where that makes sense, but then bring a local focus to what does it mean for our population. So trying to work at the right scale in the right way to make sense of that. And it's in the paper and I'm sure you'll set that out. But and as part of that, the establishment of ICBs, there was a really clear approach towards the delegation of responsibility from NHSE into ICBs, and the pharmacy, optometry and dental was the first part of that delegation process, which happened on the 1st of April. For those of us that have been involved in commissioning in the NHS for a number of years, when I was in a PCT, I had responsibility for, as Director of Primary Care, I had responsibility for pharmacy, dental, general practice, optometry. And then in 2012, in the health reforms, when CCGs were formed, they were moved out and moved to NHS England and have been in NHS England since then. And now they've come back into local systems again on the 1st of April. So just some context in terms of where these services have been and the commissioning responsibility for them. I'm going to hand over to you to take us through pull out the main points of the detail, and then we'll get into the discussion.
Thank you. And just to confirm as well, Kate and myself have also followed dentistry through all those reorganisations, from PCTs to health authorities. So we've been around a long time. So thank you very much for inviting us here today to talk about dentistry. It's been a very challenging period for dentistry because of COVID, and the paper sets out many of those challenges and what we've been doing to try and mitigate and to get better access for our patients and move access in the right direction. But I thought it would be helpful to set out, first of all, within the paper, the dental services that we've got available to us across Shropshire. I lead for primary care, and I've set out within the paper the high street dentistry, and then I've included details of our orthodontic provision, moving then to intermediate minor oral surgery services, which is a halfway house. It's a service that can be done within specialist practices within primary care. This is for complex extractions. And it saves patients having to go to hospital, and it's much more convenient and much more cost effective. I've given a summary of our fantastic community dental service and all of the things that they provide for us. They really are the backbone to dentistry. I think they fill the gaps that occur in terms of patients that can't get dentists, for example. They are our fallback positions to ensure that every patient has access to urgent dental treatment if they need it. And then I touch on the secondary care provision, and we've got obviously the local provision with the hospital here, but it doesn't exclude local residents being able to go access hospitals like the Birmingham Dental Hospital and other specialist centres. I thought it would be helpful because the paper goes into detail it talks about UDAs, which is the currency with dentistry, and a UDA is a unit of dental activity, and that's the currency we commission at dentistry. So I thought it would be helpful to put a table in, and it's there on page 2, that sets out how you, as patients, you may be familiar with the different treatment bands. So if you go for a checkup, it's a band 1. If you have filling, it's a band 2, and if you have something that requires lab work, it's a band 3. But I thought it would be helpful to set out the different treatments that fall within the different bands, but also to give you an indication of how many UDAs a dentist gets for providing a certain level of treatment. So one UDA is a checkup. And I didn't put it in the paper, but I thought it would be helpful to highlight that a full-time experienced dentist on the NHS would be expected to deliver about 7,000 UDAs a year. So I hope that puts into context those numbers. I also included a patient charge element as well for the different bands. I've touched on COVID because COVID has had a dramatic impact on dentistry. We had a period where all dentistry was suspended across the country because of infection control issues and social distancing. We had to very, very quickly set up urgent dental centres so that we could strategically deliver urgent dental treatment for patients. And then following this period where dentistry was suspended, the paper sets out how we have incrementally increased the delivery that dental practices should be providing. So it's gone from 20% of their contract between 8th of June and 31st of December 2020 back up to 100% of their contracts now, which has been in place since the 1st of July last year. And that, again, has had a massive impact on patient access because the practices have not been able to see the number of patients that they would have seen had we not been coming out and being in COVID. And the overall impact of that lost activity is the equivalent of every dental practice being closed for a year. And that's why patients are now struggling to get access with dental practices, because the dental practices are continuing to try and deal with the backlog of patients. The paper sets out how the delivery has been for Shropshire. In this case, we can't disaggregate Shropshire, Telford and Wrekin, so it's Shropshire, Telford and Wrekin's figures. But it sets out how you've compared locally, nationally, and across the Midlands. And you are it's tracking England and it's tracking the Midlands. So we're within the range where we would expect to be. The paper also sets out the levels of access pre and currently in terms of patients, the local population that are accessing. So prior to the pandemic, roughly 55.7% of the population accessed NHS dentistry, and that has fallen now, and it's on the increase, but it's currently sitting at 48.3%. So we've got some way to go to get back to where we were. And the charts within the paper set out the very lowest point when access was at its lowest and how we are getting back into recovery. But it would be really helpful for you all to hear a lot of the initiatives that we've been done, because we've not just let this happen to us. We have been actively working with dentists to try and get access back up. So we've had lots of local initiatives. We've supported practices in the early days of getting ventilation surveys done so that they could put better ventilation systems in the practice so that they didn't have to have rooms shut down for so long after certain procedures. We've commissioned weekend access sessions so that this enabled practices to see more of the patients that they would want to see, but they couldn't because of the restrictions during the day, so they've opened up at weekends. We have invested heavily in waiting lists initiatives for orthodontics. We established a Golden Hello scheme for the Midlands, and we particularly targeted rural and coastal areas, and Shropshire was included within that area. And it was very much in recognition that it is really hard to recruit new dentists at the moment, and rurality plays a big part of that. And we found that a lot of dentists that previously were commuting into Shropshire from Birmingham, for example, no longer want to make that journey. And we've had to try and incentivise not only the recruitment but the retention. And that scheme that we produced in the Midlands has been highlighted as a national exemplar. And the page goes on. I know we're going to run out of time if I keep going through each one, but it sets out the things that we've done locally. There's a lot of health improvement work there, because dentistry is not just about access, it's about health prevention and making sure that our population are orally fit. We've mentioned also some of the recurrent things that we've done. So we've established a dental advice line, and again, this is a fantastic service, I think, for Shropshire, and it means that everybody has access to that clinically led dental advice line, and they can triage patients and direct them to the most appropriate places. I am very pleased as well to be able to report that we finally secured a new practice in Oswestry, and this has been a number of years in the making. Oswestry had a contract that terminated some years ago, and it was the re-procurement of it was we had a procurement initially that failed. We couldn't find anybody. We went out with a much more improved offer because we had that flexibility to do so, and we have now secured a provider. So that practice opened on the 1st of April, and it's an interesting one because it was a private practice that has now become an NHS practice, and all the private patients are having the opportunity to become NHS patients, and they've started a steady process of accepting new patients. A lot of oral health improvement work, as I said, and Kate's been absolutely instrumental in that. There's been some national contract reform to try and make the dental contract more attractive, and the paper sets that out. And I've set out the current challenges, which I think it's workforce. We are really struggling to get dentists. And finally, the chart at the back shows where we are in terms of numbers of patients that we had, how many we lost, and where we're back to. So we, at the lowest point, we were down to 204,914 patients that were accessing NHS dentistry. That has risen to 240,468, and we are halfway now between where we were and where at the best and where we were at the worst.
Really helpful. Kate, anything you want to add to that?
No, I think, receiving questions will be really helpful. And I think what I would say is, on the face of it, Shropshire has very good oral health. However, of course, we know that is not the case in our more deprived communities. And so very much through the oral health network that we've established across Shropshire, Telford and Wrekin, with really good links with local authority colleagues, we're focusing in on those communities that we know will have the poor oral health, and linking in around core 20+5, and that's a really important area. So we are focusing in at a really granular level at those lower super output areas where we know communities are having more challenging times and will probably have poor oral health, and focusing interventions there to support inequality reduction, and that's a real focus of the work that we're doing jointly with the local authority on a number of interventions.
I was going to pick up on the health inequality, so you already covered that off as well. So look, the really helpful, comprehensive paper sets out the challenges. I think let's open up the conversation and discussion going forward. I think the bit for me is so what and what are we going to do, and how do we work together collaboratively to build on both the health inequality, health prevention work, but also then the NHS dentistry piece, and what does that look like? Lynn.
Thank you. So I'm Lynn Corley, Chief Officer of Healthwatch Shropshire, and I just wanted to tell the board that Healthwatch Shropshire have always shared the comments that we've got from the public with Daryl, and Daryl's always extremely responsive to that. And of course, we did share our report that we published back in September 2021, where we identified the limits of access to NHS dentistry, particularly in Oswestry and Market Drayton. So it was really great to be involved in the re-procurement of that practice in Oswestry. So our information officer was part of that process, which was really good. And the other things that we really picked up when we were asking people about this was one of the challenges was that people were being told to go to the NHS England website to look at which practices had vacancies, and that wasn't really being well looked after. And so I don't know if you can let us know if there's any work being done on how that is being monitored to make sure it's as accurate as possible. And then the other thing that really became clear to us was the lack of public understanding about what it means to be registered as an NHS patient, because so many people think it's the same as being registered with a GP, and it's not the same thing. So I don't know if you just wanted to explain that a little, particularly as this is a public meeting.
Absolutely. So I absolutely share the frustrations around the Find a Dentist on the NHS website. It's the for those that don't know, there is an ability on the NHS website to search for a local dental practice. You put your postcode in, and it should, prior to COVID, it used to give you lots of options, and it would tell you how far away that practice is from your home. And then as we went into COVID and practices then started to struggle to deliver access, the practices have started to close down they have to maintain the website, but they can say that they're not currently accepting. And that's what's happening now. Yeah. I can say in certain areas of my wider patch, there is a slow trickle of practices now that are starting to open up. What we have got, so absolutely that site is not always helpful to patients. It was far more helpful prior to COVID than it is now. But what we have got is our dental advice line. And what we do is our dental advice line, which is provided through the Shropshire Dental Community Service and provided by Shropshire Healthcare NHS Trust. They are in constant contact with local practices, and when practices have got the ability to take patients, they are letting the dental advice line know, so the dental advice line can then start to transfer to signpost patients to the local practices. Problem is if you put something on the NHS Find a Dentist site, we're finding if somebody puts something on there, say they're open, they're pulling patients from 100 miles away.
I think the challenge for us was it did say on there as well, if you're having trouble finding a local dentist, contact your local health watch, and we were being inundated. So I went to Health Watch England and I said, can you just do something about this, please? Because we have not got the answer and we've not got the resource to deal with it.
I think the key message is phone the dental advice line, because if you have got an issue, clinicians there can triage, and for some people I don't mean they need reassurance and self-care, and actually having a conversation with the clinician can help to reduce that stress and worry, because we know, if you're in a lot of pain, things can, get out of proportion. And it's really important that the advice line can help triage people. We haven't got any magic answers, but if you have an urgent need, that can be addressed and sorted clinically.
Really helpful, thank you. Paula?
Thank you, Chair. Yeah, really welcome the report. I'm Paula Mawson, Assistant Director for Healthy Populations, as part of the health team. And I just wanted to draw, a highlight, Kate, to a couple of the initiatives that I know you've been working on really closely with the public health team and staff, and particularly the ones that are focused on our youngest children. So the ones where we're trying to get, out into communities to make sure people have got access to toothbrushes, toothpaste, and that we're developing those really positive habits from the get-go, particularly because we know that one of the leading reasons why children are not in school, if they're in hospital, is because of that dental decay. So the more I think that we can support that work and join up, I would really, really welcome. And on that vein, the other one that you've mentioned in the report is the work that you're doing at the ARC around supporting the homeless. So we have an initiative called Reset, which is a new multidisciplinary team working at the ARC that's very much focused on people who are homeless but with substance misuse issues. And I wonder if there's an opportunity for us to join up and consider that broader team as part of this, so that they're aware of the issues and can support in the work that they're doing as well.
Yeah, thank you. And sorry, just touching on there about the toothbrush and toothpaste. One of the things, we're very aware of the challenges around access, and NHS England had some money left at the end of last year. And so, whilst it's a very small thing, £40,000 has been allocated to the local authority to purchase toothbrushes and toothpaste, not just focusing on the core 20 population that we would traditionally focus on, but any individuals where the money doesn't go as far, and that's going to be freely available across the area, and I think that will probably extend for quite some time. So that will be promoted through a whole range of avenues for adults and children, appreciating it's in a small way, but again, if that can just help people get by on that sort of thing, we're very pleased to do that, but we don't underestimate that it's just a small thing.
Really helpful. I didn't see whose hand came up first online, sorry, so I'm not sure between...
I think it was Patricia.
So Patricia, and then I'll come to you, Councillor Motley, if that's okay.
Yeah, just in relation to the comment, so apologies for joining late. I'm part of a subcommittee, one of our board subcommittees, so I've just come out for a couple of the items on the agenda. Just in relation to the point on the dentistry delivered at the ARC, Shropcom actually provides dental services to the ARC currently. We're commissioned to provide dental services for adults and children with complex and specialist needs. We also run 3 general dental services practices in some of the most deprived areas of Shropshire and Telford. So we have one in Oswestry, for example, and in the centre of Shrewsbury. So we do provide dental services, and we're really keen to be part of some of the solution around the desert of dentistry that exists, not just within Shropshire, Telford and Wrekin, but something that's a national issue. So we do provide currently dental services to the ARC. Very keen to look at how we can be provide better services there if that's required, and also be part of the conversation around the solution to do with general dentistry across Shropshire, Telford and Wrekin as well.
Thanks, Tricia, really helpful. Councillor Motley.
Thank you very much, Chairman. Yeah, I'm Councillor Cecilia Motley. I represent a very rural division in Shropshire, and I'm interested in the problems of rurality with regard to dentistry, because I can imagine that first of all, it must be difficult to find a lot of dentists operating in rural areas in the first place. But I'm just wondering if there's a problem about take-up, particularly from elderly people living in rural areas, in terms of dentistry, which involves having to go into one of the market towns in order to access dentistry, just because, you know, public transport is extremely sparse in the rural areas. And I'm just wondering, are there any instances of joint cooperation going on between doctor surgeries and dental surgeries within the rural context? Because if not, is that something that might be helpful to see if one could work towards?
Thanks, Councillor. Darryl, Kate?
There isn't anything ongoing at the moment. I'm assuming what you're meaning from this is the co-location of dentists and doctors in the same building, yes.
Yeah.
So historically, when we've built new health centres, we've always invited dental practices to relocate. There's quite a difference between the way dentists and doctors are reimbursed for their rent. So a doctor going into a new health centre has all their rent reimbursed. It costs them nothing. A dental practice doesn't have that, so they are responsible for their own rent. The only help they get is a contribution towards their business rates. And so when you look at a new health centre, a doctor's practice, the cost of them going into a health centre is usually much greater than the premises that they currently rent, and that's quite a barrier to getting them to move to other areas. But practices could, for example, if there was a need and there was a desire, they could open a branch site in some of the rural areas if there was an appetite to do that.
Yeah. Okay. Thank you. It's just that it is a problem, because I think what tends to happen is that people living in rural areas tend to put dentistry rather at the bottom of the list, just because it's more complicated to access. And I'm just wondering whether you've noticed that is a feature.
Now other colleagues want to come in. I think I'll bring other colleagues in, but I think in terms of when we get to the recommendation piece, there's something about how do we best use the Health and Wellbeing Board and the work around inequalities to look at the rurality challenge with dentistry.
Yeah.
Because there's that aspect I think that's really important, as well as there being an aspect of how do we just make sure we commission dentistry for the population that we've got responsibility for, but where can the Health and Wellbeing Board bring added value? I think it's some of that inequality piece and really targeting and looking at that and saying, so what are we doing, what are the approaches we can do, what does that mean, and what does that look like? But I'll come back around to that. So Jackie, then Lynn, and then I'm going to move us on, if that's okay.
Right, thank you. I'm going to ask a question I feel I should know the answer to, as I'm the Chief Officer of Citizens Advice. But when it comes to actually people who are registered on for NHS dentistry, there's still a charge, isn't there? And there is support for people on low income. But when they ring the helpline, does the helpline help them apply or to register for that help on low income, or is this something that we need to address through the hardship and poverty group? Because when we talk about health inequalities, you know, certainly for my clients, we're getting more and more people coming with negative budgets who can't even afford to eat, never mind pay, you know, half of £25 for some very basic care. So I do think, is there any help? Do you have any examples of where people have not taken up care because they can't afford it? Should we put it onto the task list, Rachel, for the social task force?
I don't have any examples, but I'm absolutely certain it exists. There is help for certain categories of patients with low income, and the dental practices should know how to direct patients and to guide them in terms of whether they are exempt from payment or not. The dental advice line, I'm making an assumption they know how that works as well, and my assumption would be that they would also guide patients, but were having difficulty in terms of paying for NHS dental treatment. So, but it is, I think, something that we could promote better.
I think awareness of the HC1 and application, and for some people that can be a challenge. I know when I worked in practice, I would sometimes sit with patients to actually fill it in because I knew they perhaps wouldn't be able to otherwise. So there is something about kind of supporting that, because it's a process that people may be very unfamiliar with, or have moved into an area where they would get even partial support but don't know about it. And of course you don't get free dentistry once you're at retirement age, and like for prescriptions, etc. And people don't necessarily understand that. So I think it is an area that raised awareness and support would be helpful.
I'd take that forward then and put it on. I think that's something that we can do just to raise awareness. I would hate people to be prevented from taking up treatment with the worry that they couldn't pay their contribution.
And the challenge as well is if you do turn to practice and you may be on a low income, the dentist has to still take the money and then say you can get it back. But that's very challenging for people, isn't it?
So, Darryl, I saw a couple of hands up, and then I do need to move us on.
I just wanted to come back on the registration element because Lynn asked it and I never answered the question. Patients cannot register with a dental practice, and it is a myth that they can. It's very different to registering with a GP practice. You absolutely cannot, and ever since 2006, register with a dental practice, and that's a message that we do try and relay as much as possible. It's not helpful sometimes when a dentist talk about registering with us. I have set it out in the paper. We do work with Health Watch around trying to get that message out, but it is a myth out there that they can register, but they can't.
The only other point I wanted to add that was really clear in our report and really startling to me was the issue people have around broken dentures, and the impact that has, particularly on the health of older people if they can't eat. And also those people who've lost their teeth due to medical treatment or illness and the trauma of that. So I just wanted to raise that and wonder if that can be part of that conversation regarding support, because people just feel that once they've broken their dentures, they have no option but to not have any teeth or any help to eat. And so I think it's probably having a bigger impact on those older people or people who are using dentures.
Any final point, and then I'll move us on.
I just wanted to ask if, obviously, you've been working closely with Health Watch, and I said that's really, really positive, and Health Watch is very supportive of the system in a range of ways. But I wondered if you feel like you understand well enough the kind of needs and views of the people of Shropshire kind of across the board to be making decisions and developing things going forward. And I guess the other side of that is there more support needed around communication? Because I'm wondering if you feel like people know about the helpline, do people know about the kind of offers that are on? Do you feel like it's well understood?
I would like to think the dental advice line's only been there a short period of time. It became a clinically led advice line during the pandemic. I think we can't over advertise it. There's a lot of work going on to promote it, but any assistance in getting that number out there, because that is going to be the lifeline to patients that don't know what to do. So whatever help we can get to promote that would be fantastic. And in terms of understanding the needs of patients, but before we embark on any change to a service, such as the procurement of the Oswestry service, practice, we do engage with patients and we find out what they want, what services. So we knew that the hours that they want the surgeries to be open, we know where they want them to be, we know that they want them to be accessible, we know they want car parks, we know that they want wheelchair access, and those are all the things that we build in to any procurement that we do, which is why it was really helpful to have Health Watch on board with Oswestry, because Health Watch were the patient's eyes in everything that we did on that procurement.
And I think as well, one of the things Darren and I have been talking about is I'm going to do a health equity audit to just kind of start to understand, ward level, what are the access rates like, and so actually where do we need to kind of address some of those issues. And I think then it'll be really useful through our links with public health colleagues and their links wider in the local authority and beyond. That will enable us then to do some of that engagement with local populations, because I think, coming in, bringing people at the end is no good. Actually, it needs to be a constant conversation, doesn't it? And that's something, I've always felt we all from personal level, need to get better at. So, I know I can link with colleagues in Shropshire local authority and we can, work in specific areas around that. So I don't think we do it personally as well as we could in certain things, but I think there are opportunities to do more of that.
So, Gerald, Kate, thank you for the paper. Thank you for coming this morning. As I started with that, a really helpful conversation. The recommendations in the paper was to note the contents of the reports, but I think we've gone beyond that to some extent, because I think there's a few areas that we need to pick up. So I think there is absolutely something about the health inequalities and rurality piece that we need to, the Health and Wellbeing Board will want to have a continued focus on. So I think we should agree in a forward plan, when do we bring a view back into an update in terms of that? How do we continue to work with you as part of the system in that space, as you're now part of the system? So I think there's something around that recommendation in that area. There is something about the comms piece, I think, and Penny, you touched on this, Jackie, you touched on this, Lynn, you touched on this, that a more coordinated approach towards actually when do we combine all of our comms teams and have a real push on, here's the, we're going to have a dentistry month, or we're going to do something in terms of where we really look to promote, and how often do we do that? So I think there's something around the comms and engagement piece that I've heard come through from the conversation. And with that is the information piece of the telephone helpline, the other support that's in there, the voluntary support, the citizen advice piece. So how do we package that piece together? And then there's a whole piece then around the future of NHS dentistry in Shropshire, Telford and Wickham, both in terms of rurality challenge, recruitment retention piece, opening up in increased access, and how do we get into that piece of work in the right way as well, and work as partners in that space. So if we strengthen those recommendations, build that into the forward plan, pick that through some of the health inequalities at work, does that capture the conversation that we've had this morning? Yeah. Okay, you'll have to
Yeah,
about to just I keep reminding you to press the button just because we're live streaming to the public as well.
Yes, one thing, and I'll get told if I don't say this. It's just a flag, because I think this is a good setting around the recruitment. I think there's something about growing your own workforce throughout the whole dental team, and certainly in Staffordshire through the STEM Ambassador social enterprise for Shropshire and Staffordshire, there's been a really useful careers fair for young people. They'd like to do it in Shropshire, but at the minute I think there's a challenge in terms of finding perhaps the infrastructure or somewhere to host it, and they were wondering about support. We've got the people who can do the doing. It's just, are there opportunities to kind of make it happen?
Absolutely. People are nodding. It was an immediate yes for me. So it was like yes. So
we'll connect with you.
Who's best to pick that? I've got
Tanya, Rachel. Obviously.
Yes.
You've got my details, and I'll link to Tanya.
Yes,
so that's a yes.
Local dental network chair. So sorry, that was a bit kind of.
No,
said that before, but
use the opportunity.
Yeah,
absolutely. So thank you for that, and thank you for the conversation this morning.
Thank you.
Thank you. Thanks, everybody. Got a little bit of catching up to do, so I'm going to move us on quickly, if that's okay. Onto the agenda item on early intervention prevention, the test and learn sites in Oswestry. So Mel, you're here, but Rachel, I think you're starting, and then handing over.
Yeah, if that's okay, thank you, Chair. I just want to provide some context for this. So in re-looking at the agenda format, one of the key principles of the Health and Wellbeing Board, and actually the Shropshire Plan and the ICS strategy, is clearly around prevention, early intervention, and writ large in the Hewitt review that's just come out is the need to focus much more upstream and on prevention and that investment. So as part of that, we've agreed that as a standing item on each Health and Wellbeing Board agenda, we will focus on prevention. To help us and aid us with that, and to be really clear about what we mean by prevention, early intervention, and our very ambitious approach that we want to take across all ages in Shropshire, Telford and Wickham, we are developing a prevention strategy, which we want all members of this board to sign up to, commit to. But before we do that, co-produce and develop that. There's a lot of work that's already been done around children and young people, and Mel's going to take us through one of the examples today, which has been very much a collaboration across public health and social care and early health within the council, and actually across all parts of the council, but much more widely it's across the system. Shropcom have been very, very involved. The police are involved in this, all of our partners. So Mel's going to, I won't steal Mel's thunder, she's going to talk about that, but actually it was to set the context that we will be bringing back, and I would ask if after the next session, if I could ask members of the board to stay back for some time, and we will help develop and co-produce the prevention early intervention strategy that we want to own collectively as partners. As I said, it'll be all ages. It will involve some of the work we're already doing, outlining our vision, but those priority programmes that we want to put in place in Shropshire to make sure that we get upstream, support people as early as possible, ideally prevent people getting ill or needing complex help, but where they do, it's that approach, that secondary and preventative approach, because we know that will improve outcomes for people. We know that's what people want, and it will reduce demand on our services as well. So it's a win for everybody. So I just wanted to put that in that context. This is one of the programmes that we've been doing a lot of work around children and young people. We've got a lot of work already going around adults, but we'll bring that together, and I think if we can present that systematically and work with colleagues to where do we want to focus. And it picks up on lots of the things we've talked about today, so that trauma-informed approach, the integration, how things need to look different in a rural location. So actually, how do we, everything's not the same, and actually if you look at our communities, how do we wrap those services around into some of the work we talked about the last board in Highley, and all underpinned by our JSNA and our data. So we'll start to weave that together, but sorry to steal that time, but I think it's important to say that this will be a standing item on our agenda. Thank you to everyone for the commitment, and if we can have that session after, but this is just as a seed for the wonderful work we're going to be doing in our commitment around this.
Not time stolen at all, really important. And Mel, as ever, assume the paper's been read, so pull out the main bits and then let's get into the conversation about it. Thank you.
Right, thanks Chair, thanks Rachel. So yes, this is about the integration test and learn. So I thought initially I'd just put a little bit of strategic context around it. So Shropshire's Integrated Place Partnership, which is known as SHIP, of which Shropshire Council is a partner, has agreed this particular roadmap for prevention, early intervention and integration. And as you will probably know, integration is one of the priorities for the Health and Wellbeing Board. One of the main priorities for SHIP is around infants, children and young people, and the agreed vision for them is to live their best life, which also comes from the Shropshire Plan. The integration work can link closely with personalised care and could be one of the vehicles for delivering the local care programme. It is data-led, and we've taken both a scientific programme management approach, but we've also complemented that with a people-centred service design approach. So we are co-producing the work by involving the practitioners, the community and the children and family themselves. You might ask why integration? I think we all recognise that most of us struggled throughout and after the pandemic, and we also recognise that COVID hasn't actually gone away. And this has created an environment of uncertainty for many people that live in Shropshire today. We have seen increases in mental health referrals, particularly for children. We have seen a deterioration in speech and language progression for many of our children, and also in general school readiness. And we understand that many people who isolated throughout the pandemic are still isolated, and we have seen an increase in children being electively homeschooled, which has created some further isolation for them. We know from a recent survey of young people that nearly 60% of those who answered don't leave the house after returning home from school each evening, which I actually found to be quite a shocking statistic. I mean, I don't know about the people in the room or online, but I know certainly when I arrived home from school, I would literally fling my bag through the door and then I would be off out. But that unfortunately doesn't appear to be happening at the moment. We also know that many voluntary and community sector initiatives that were well attended and thriving have failed to restart or reopen following the pandemic. And this has left gaps in local provision for many areas. And not just the rural ones, but some of our larger towns have also seen gaps arise in community-led provision and support. Our service managers and practitioners on the front line are also reporting an increase in challenges for people alongside the cost of living crisis. This has seen a rise in poverty, particularly around food poverty, domestic violence and substance misuse. And senior managers at SHIP have agreed to commit and support integrated services wherever possible. And that means inputting resources, skills, knowledge, and a commitment to find new ways of working together to avoid duplication, failure demand, and to give people we work with a clearer, quicker and more positive experience, resulting in better outcomes and helping them to thrive. The work that we've been doing up in Oswestry has focused mainly on children, young people and their families. And it is something that I passionately believe in, alongside the fact that every child can be whatever they want to be, and wherever they grow up and whatever the circumstances they grow up in does not define or restrict them. And this piece of work very much focuses on that. So what you'll see now is Shropshire's integration model. It focuses people being at the centre and supporting themselves. I know that we've talked about this already today. So it's about people making those good choices for themselves and having easy to access universal services which are quick, reliable and that work for them at the right time. What you'll see around around those people, the lighter green circle, that's the local community voluntary sector and friends and family, which we would like to be their first line of support. And then in the yellow circles, you'll see the next line of support comes from localised services such as schools, childminders, GPs, sports clubs, that kind of thing. The orange hexagons around the outside are what we would wish for them to be their last line of support, really, and include things like our NHS community services, social care, A&E, specialist mental health, police, fire and rescue. Currently, many of the families that we're working with are presenting in the outer circle, and some of them are actually not known to services until they reach crisis point. So the aim of the integration work is to build the community-led offer and to identify and encourage children and families to tackle issues early on to prevent them from reaching that crisis point and to stay within more of those inner circles. So Oswestry, the integration test and learn, Oswestry was our first site. So that was chosen very much, it was led by population health data. So we recognised that there were areas of deprivation in Oswestry. The work up there has taken, it's been in two parts. So the first part has been around creating that multidisciplinary team. It includes around about 15 practitioners, and I say around about because practitioners actually come and go depending on what the need is at the time. But we have had practitioners from right across the system. So we have community midwifery, we have midwives and staff that join us, FNP, school nurse, health visiting, the mental health team for schools, the police, we have social care, targeted early help, school exclusion, safeguarding, public health, gypsy liaison have joined us, social prescribing, targeted youth support, the list goes on. I think one of the most interesting things for me when we were forming that team was that the first time that we met, we very quickly realised that the practitioners sat around the room didn't actually know each other. But many of them were working with the same families. So one of the aims and one of the things that has happened up in Oswestry is we are starting to do joint visits now, which is fantastic, and it does make a difference to the family. Ultimately, our aim would be to use one system. Whether that will eventually happen, I don't know, but we are actually training all of the practitioners on the Liquid Logic system, which is our EHM. And I know that certainly some of the practitioners have already said what a difference that has made to be able to see that holistic whole view of the family. We are taking a whole family approach, and the practitioners also offer support and supervision to each other. The second part of the integration test and learn is the community collaborative. The community collaborative has been fantastic. It supports practitioners by filling gaps that they're identifying within the community. The community up at Oswestry is extremely supportive of this. They're really committed to supporting each other and also to supporting us across the system. So we have, as an example, we have an initiative called OSNOSH, which is very much around food waste. So they don't concentrate on poverty itself, but they talk about not wanting to waste food. It's a fantastic initiative, and they work on a pay-as-you-can basis. So quite often our practitioners will meet families who we know may be in particularly difficult circumstances. And they will actually meet them at Osnosh and they will eat with them while they have their meeting, which has had a really fantastic and positive impact for those families. We recognise that it's not an altogether new approach. However, what we are doing is we are taking the best practice and the learning from those teams that have previously existed or are still in existence, and we're building on that alongside the commitment we've received from our senior leaders across the whole system. I suppose I've worked in local government for 26 years now. Some of that was with the probation service. The majority of that has been at Shropshire Council, but I have also spent some time in the NHS, particularly on the vaccination programme. And I think that one of the major learning that I really took away from the vaccination programme was the partnership and the integrated working that happened there. It transformed everything that happened during that programme. And for me, that is the way that we should work going forward. Our process and systems are not easy to navigate, not even for us as practitioners. So, we can create some unnecessary delays in getting early interventions to people, and we need it to be so much slicker and quicker so that we can avoid that escalation. Aims of the integration programme, I'm not going to read them out to you, but it is about reducing demand across the system for both health, council and our other public sector partners. The work that we're doing is currently being independently evaluated to evidence the results. My instinct, and the instinct from the practitioners and from the community, is that this is having a positive impact. And we're going to have the initial results of the evaluation at the end of May. So I would look forward to bringing those. The team have been working on cases jointly with some quite complex needs, and we are just testing a new panel approach for practitioners to bring family stories and circumstances to the team. At Shrewsbury, we're going to be starting that very soon. Taking that multi-agency approach, and we're going to be reviewing the impact on those infants, those children, those families quickly so that we can make sure that we're getting it right. And the next phase will be to roll out this approach across the county. So we are expecting to have 5 integrated teams right across Shropshire. The next site is actually in North Shrewsbury, and the first meeting is being held this afternoon. So we are moving quite quickly on this. Last week we had what we termed as a refresh meeting. So this piece of work has been ongoing for a few months now, and it was being led by myself and one of our most experienced public health consultants, who has actually recently retired. So we decided that we would actually have a refresh meeting. So we would take all of the learning that we've learned so far. And that happened last week with senior managers from across the system, and we had some really positive outcomes. So we confirmed the commitments to this piece of work, which for me was great. And you'll see the commitments are actually up on the screen. We're currently working on the vision, because we think that that's really important for everybody to understand that. And the work is feeding, as Rachel said, into the all-age early intervention prevention strategy. We have agreed the next site. So obviously site 2 will be North Shrewsbury, and that is starting today. Following that, we will be looking to move to Ludlow and Market Drayton. And then we do have one other area which is yet to be confirmed. At the refresh meeting, we also agreed a leadership structure was needed, and further conversations are being held as to how we're going to deliver that. But what I am absolutely certain of is that we do have buy-in and commitment from right across the system for the integration work. So, as I say, the next steps will be the rollout to North Shrewsbury, and the rollout will explore working across the system, implementing the all-age early intervention and prevention strategy, with sites 3 and 4 being Ludlow and Market Drayton, following by the end of this year, and a 5th location to be agreed. You've heard Val talk about the trauma-informed approach, and that is something that we will be taking across the integrated teams. So working to build and create that multidisciplinary team in local areas. And as Rachel said, it will be to meet local needs. So each of these teams might look and feel slightly different. We'll also be supporting the development of the health and wellbeing centres where our integrated teams are hoping to work from. As I said, we recognise this is not a wholly new approach. So multidisciplinary teams have been in operation before and some are still in existence, and we want to build on that best practice. For me, the time definitely feels right now for integration, and I know that the commitment is there, certainly from the practitioners on the front line and from senior leaders from across the system. So thank you. If you've got any questions.
So really comprehensive and both in terms of the paper and in the update today. So a lot in that. Let's pull out the main points. I've got hands up online, but Jackie, I think you were first.
Yeah, thank you. So in the targets and milestones, flashing green, you say that you're going to create a community prevention offer for local residents that's led by the VCSE. So who's doing that, and does it link in with Rachel's work and the discussion that we're going to be having at the end of this meeting?
Yeah, so I suppose, I mean, that in itself, Jackie, is those community collaborative meetings. So I think that the community, certainly up in Oswestry, I mean, you have been to some of those meetings, I know, has really risen to that, and it does feel that they are leading on that. Obviously, yeah, we are supporting that. We have recently had the Thriving Children Fund, which we released, which is working with town councils and the VCSE. So yeah, so that is being. So who is it? Yeah, is what my question is.
I think with that statement, sorry, can I come in? I think what that. I think what that statement is saying is that we recognise the importance of the voluntary sector in this, and actually we need the voluntary sector to work with us, and you are working with us. There's also is also crossover between the Community Connector Network and the Community Collaborative, so we need to do a little bit of work across that contract, which is part of social prescribing, to see how we can make kind of best use of resources across both of those things. So it's a work in progress, Jackie.
So could I suggest, because we could do backwards and forwards, could I suggest that the conversation around the who, what engagement, how, what does that look like, is picked up as an action from this conversation?
I would welcome that.
Thank you. Okay. Thank you. So I've got a couple of hands up online as well. I've got 3 hands up online. So I can't see an order. So if somebody could give me an order, that would be helpful. Or I'll just go with people. Patricia.
Yeah, I mean, this is a huge piece of work that we should celebrate, actually, because this is Health and Wellbeing Board in action, isn't it, in terms of targeting a population approach to health and bringing services together with the view that we really start to tackle some of the health inequalities and promote good working across children and young people. So I think, you know, this is a tantamount of, this is the whole purpose of Health and Wellbeing Boards in terms of tackling these kind of issues. So this is Health and Wellbeing Board action in action. It's integrated care system in action, actually, in terms of bringing partners together, again, around population metrics and focusing on really tackling some of those health inequalities. But also, I think where we need to be smarter on this is picking out those kind of key, both qualitative and quantitative metrics. Certainly from a Shropcon point of view, we've seen a real improvement in recruitment of staff, because we've had 5 new health visiting students started on the back of this in terms of interest from universities around training placements, because this is all about health visiting and public health nursing. So that's had a real positive impact for us in terms of also retention of specialist skills and expansion of skill roles. And the point made around interconnection of roles and new ways of working across local authorities with our acute sectors, but also more importantly with communities themselves and with the voluntary sector and police has been phenomenal in terms of being able to pick up the phone and deal with issues and supporting people in a different way. So this is where we need to get to as an integrated care system, and this is a real example of how we've done that in one area. So for me, it's a comment of how exciting this has been. The feedback from staff across all partners has been phenomenal, just in terms of the positivity it's given them, the purpose back in terms of their role and function. So I think this is something that this is a horse that we need to back. The area that we need to now get into are those harder metrics of how we are changing fundamentally people's lives in those areas and turning the dial on inequalities. And also looking at the resource allocation around that and appropriate use of resources in terms of bringing those teams together. So I think this is a really exciting, positive piece of work that we should be celebrating as a real success of both Shropshire Health and Wellbeing Board and the integrated care system working in tandem, really.
So really helpful, constructive, Patricia. I think to build on that, I was also thinking this needs to be a vignette in the joint forward plan in terms of actually this is what we're already doing. This is what this can look like. Here's the potential of what we can do. Where do we go from there, and how do we roll this out to build in both the celebration? Because otherwise, there's a risk. The joint forward plan is yes, we've got an ambition, but actually we need to build it on what we're already doing. So I'd quite like to make sure we've got the right vignettes in to say, here's an example of where we've already got to, but how much more can we do with it, and where do we want to be going with it? Linking to another agenda item, and Claire's joined us as well. Kirst.
Sorry about that. Couldn't get off mute. I won't repeat what Patricia said because a lot of it I was going to say. But thank you to Mel and the team. It's wonderful when we can hear such positive feedback. And just this, controlled phased programme has really worked in understanding what's worked well, what hasn't, what you'd repeat. And you cannot beat local knowledge and this localised instead of a one blanket approach across Shropshire. This absolute sort of community led offer has been invaluable, and we are hearing that feedback through local members that we brought on board really early and having those early conversations with the community. So it's just a really big thank you to everybody and everyone that's been involved in this, because we are now seeing the benefits of it, and let's roll out some more. Thank you.
Thanks, Councillor. Ben?
Yeah, thanks, Mel. Just noted in the report that you highlighted potentially some issues around engagement with CAMS, and just wondered whether that had been resolved, and if it hadn't, if there's any help I could give in facilitating further conversations. And also just to sort of note that in adult mental health services, the sort of integrated models also obviously very much at the heart of the sort of transformation programme, and we're developing sort of multidisciplinary teams based around PCNs, which will pick up some of these broader sort of holistic issues that people face. And I guess just making sure that we're sharing that information to where we're sort of commissioning additional capacity around sort of financial well-being and housing and so on. We're not duplicating efforts.
Yeah, thanks, Ben. I would certainly welcome some support with, maybe understanding a little bit more about CAMS. We are working with them, and they are committed to this. But I think there are some more conversations that perhaps need to be had. So I would welcome any support with that. Thank you.
So if we pick that up as an action as well, Ben, if you could pick that up, that would be really helpful, because it just builds on that model. We can't have the model, can we, if we've not got the bits that plug in around the sides, around the edges of it. Lynn.
Just a quick one from me. I was the first children and families social worker in Shropshire to be on a multi-agency team in Ludlow in 2006, I think. So I'd be very happy to speak to you about. And what's really great to hear is the level of buy-in across this system at this moment in time. The issue around CAMS, was always the same. And for me, I think that issue is around the capacity of CAMS, particularly when you're looking at that more preventative model. So while I'm sure CAMS, because I've also done a placement with them, and I'm aware of the challenges, but I think there is a bigger issue we've got in this county about the capacity of preventative mental health for children and young people.
Okay. So, Mel, Rachel, anything else you want to add or say as a final? No. So look, I think again, really helpful paper, really helpful presentation. I agree with comments that Patricia and others and Kirsty and others have made in terms of how do we celebrate, how do we promote. I think there's a few additional actions that came through, one with Ben, one in terms of the joint forward plan and how do we get the right vignette in there. I think the rollout plan, how do we make sure we get behind that in the right way. I think we need to link this with the big health and wellbeing conversation that's taking place as well. So I think about the feedback we had from the Ludlow event, it was absolutely about how do we get into this space and how do we work differently in locality areas. So I think it feels as though it just clicks in the right place and we now just need to connect and roll that out and support that in the right way. So absolute commitment from the Health and Wellbeing Board. I would want the Health and Wellbeing Board to stay really close to this because it absolutely is our bread and butter of driving that integration, health and equalities, working with local people, the place agenda piece that sits with place as in a smaller place piece, how do we sit in that space? So bringing this back here as we roll it out with the Health and Wellbeing Board having the oversight of that, absolutely sign me up for that. Thank you. Good. Okay, I'm going to move us on then, and we're going to carry on with this level of positivity. Lynn, Health Watch report, calling for an ambulance in an emergency.
Okay, let me just share my screen. Hopefully everyone is able to see that. Yes. That's great. So I will flick through this.
I was about to check then.
Yeah, I'm going to.
You sent a slight shiver down my spine in terms of the number of PowerPoint slides that you then showed up there.
No, I'm going to flick. And the reason for my love of PowerPoint is I'm an ex-teacher and it gives me structure and it stops me waffling on about things that I don't need to talk about.
35 slides would still be slides.
Yeah, no. And
3 for me is like.
Yeah, I know. But unfortunately, I didn't have time to shorten this, so I will be, and I will share.
It'll be structured with 3 or 4.
Yeah, it's going to be fine. So firstly, I just wanted to say thank you for the opportunity to bring this report to this meeting, because this is one of those public meetings that I go to across the system, and it's an opportunity for me to thank all the people who shared their experiences with us for this piece of work, because we did hear from a lot of people about this issue. We realised it was a contentious issue, and as Health Watch we were very aware of the challenges across this system, but it was about bringing that patient perspective and the public voice to the table. So we all know why we did this piece of work. So if I just explain what we did, we worked with Health Watch Telford and Wrekin to make this ICS wide. We promoted it through all of our channels to ensure that we reached those people who might struggle with digital inclusion, and that included going on the radio. And as with all of our pieces of work, people could always just give us a ring to share those experiences. They don't have to be able to go online, and use our free post address. So we heard from 168 people. Now, 8 of them were from Telford and Wrekin, and I just want to point out that I don't think that means that there isn't an issue in Telford and Wrekin. There is a disparity in terms of capacity across these 2 Health Watch, but also as Health Watch Shropshire, and particularly with that focus on rurality, we did put a lot of work into promoting it in Shropshire. So I wouldn't want there to be particularly anything read into the issues across Telford and Wrekin. So and 103 of those experiences happened between October 2021 and September 2022. So it's also important to say that we also did capture people's postcodes on this occasion. We don't always do that, but it was particularly relevant here. So we were able to include a diagram showing where we heard from people, and it is fair to say that local councillors did take a particular interest in this in some areas, and so we're very important in promoting it, but also our MPs. So I think this is very important to demonstrate that there was a large degree of positive feedback. And for me, it's important for the system to hear that. And that feedback that was positive was particularly around staffing. And yet we are very aware of the number of people who are working very hard to address these challenges, both behind the scenes, but also on the front line. So 46 people described a positive experience and 23 described a mixed one, where they may have had a negative experience in some part of the system, but a very positive experience elsewhere. So we were very keen to include those positive comments, and it is fair to say that a number of them were around the paramedics themselves, who also, at times did share their frustration about how long it had taken them to reach somebody. But when they were there, they were kind, compassionate, and polite and very professional. And any frustration they might have had, they didn't share, particularly with the patients. So in terms of, do you like the way I'm nipping through this? It's good, isn't it? It's all that experience. I've got to really slow down now. So the negative comments, I won't go into the detail, but for those of you who have read this report, there were some very strong and very powerful experiences, and particularly where those people who spoke to us, who felt that the loss of a loved one had been as a result of some delay across this system, and so that they were particularly emotive and distressing. So I picked out just a couple of those. So for example, on this slide, a lady who was in a care home. So when we were promoting this survey, I also made it clear that as Health Watch, we're not only the voice of the public, but we also want to hear from the professionals and the staff who are working within this system. So we did put out a call as well to care home managers and care home staff and domiciliary workers who might have experienced challenges themselves when calling for an ambulance for somebody that they were supporting. But also, the challenges in primary care when they've identified someone who's in need of help, and also their frustrations at times with the time it might take for that person to receive the help that they need. So, as we always do, we see this as a really important mechanism for the system to communicate with the population. So I try not to publish any report without a response from the system, because I know that there is a lot of work happening to try to address these challenges, but it is not my place to tell the public what that work is. And so I know that there might be some frustration that I don't just say what I'm hearing at meetings, but it's really not my job to do that. So that's why I go back to the system. So it's from the horse's mouth, direct to the public. So we heard from the Chief Medical Officer about the complexity of this situation and the impact it's having on primary and community care, secondary care and social care, and how as a system everyone is working together to try to resolve these challenges. So in the report we included all the detail about what people told us about the work that's being done across the system, and the advantage of adding that into the report is then that when people read it and they're going through these things, they can tell us how they're working, but also can tell us where it's not happening or where it's not working. So one of the things that we're looking at doing going forward, for example, is to work with the Community Health Trust, and maybe Patricia's colleagues haven't told her this, but we would really like to be part of any work around getting feedback on the virtual wards. We heard about the work that's being done in South, which Nigel might want to talk about, but also the work that's being done to support care homes. And we also heard about the work that's being done to try and support people with mental health challenges, because quite often an ambulance might be delayed for a whole shift because it's supporting someone with significant mental health challenges.
So the response from the system described 3 pillars of improvement work: those community-based initiatives, the changes in processes and systems to improve patient journeys through the hospital, and the work being done to improve discharge and out of hospital support. So I just wanted to highlight that this piece of work was picked up by Healthwatch England, and I'm constantly trying to reassure our system that we're not just this, at the moment, 4 members of staff working in Healthwatch Shropshire. We have got the support of a network, and we have got the support of Healthwatch England, who work at national level with the CQC and the Secretary of State for Health and Social Care to bring the voice of our local people to the fore. And so our report was cited in a report that went to the House of Lords, and a case study that we gathered was shared there to show the level of challenge that we've got in Shropshire, Telford and Wrekin, but also nationally. And so the things that happened as a result of this report, because I was sharing our findings as I went along, it meant that the system were able to respond quickly. So I spoke at a SHIP meeting, and as a result of that, then there was a focused conversation around falls pathways in Shropshire, because there was one in Telford, but there wasn't one in Shropshire at the time. Raised awareness of things like 2 carers in a car in that meeting, because it was interesting that there were some people in that meeting who weren't aware of it. And I also raised an issue around particularly dom care agencies working with adults with learning disabilities who were having a particular challenge when they were calling for an ambulance, particularly to raise someone off the ground, that quite often they weren't getting that support, but they also didn't have the training to do it. So I was able to raise that with Shropshire Council, who then went back to try to negotiate between those care providers and YMAS. So I think it's fair to say I've done it.
So I am impressed.
I am good. I'll write that down on the feedback form.
So really helpful. Firstly, let me say thank you. Thank you from the Health and Wellbeing Board. Thank you, more importantly, I guess, from the residents of Shropshire in terms of bringing this. And thank you for the transparency, honesty and clarity that you've done that with, both in terms of the report, the work going on to pull that together, and then wanting to make this public, wanting to talk about this, but doing that with a sensitivity around the issues that come with that. So important that I put on record my thanks, and also then as the Chief Executive of the Integrated Care Board to say thank you in terms of that as well. So the report is hard hitting, but so it should be. I don't think there's anybody sitting around this table that would say ambulance delays, whether it be for when you're in the back of an ambulance sitting outside the hospital, or whether you're sitting waiting for an ambulance to be called, is acceptable. But equally, I would know that every member of NHS and social care staff would also say it's not acceptable, and colleagues are working really hard to make sure that that's not the case. The report sets out a number of areas where you say here's the improvements and what's going on, and people are working really hard in that space to improve the areas that have been highlighted and to bring a real focus to this. And it's a collaborative approach that's driving that, with partners working in an integrated way to really think about how do we get a better outcome. So I wanted to say thank you. I wanted to recognise that. I wanted to recognise the work that's taking place. And also make sure that we have the focus on how can we do better. For me, the ambulance delay measure, it's a proxy. It's a proxy of how is the urgent and emergency care system working across Shropshire, Telford and Wrekin. It's not the only measure, nor should it ever be the only measure. But as we sit here this morning, I recognise it's sunny outside. There is nobody currently in Shropshire, Telford and Wrekin waiting with a Category 1, a Category 2 or a Category 3 call that's waiting for an ambulance to be deployed. Out of the 12 longest patient delays without any handover across the entirety of the region, one of those is at Royal Shrewsbury and one is at Princess Royal, but it's 1 and 1, it's not 2, 3, 4, 5 out of those top 12, just using some of the data that I look at on a minute by minute basis, as Nigel will know and Claire will know at times if you're on call when I'm looking at some of this. So there is undoubtedly more work to do. The other piece I would say is we need to deliver a hospital transformation programme. We need to deliver the local care programme. We need to deliver the tester change and the integration bit that we just talked about in terms of Oswestry, because all of those will be elements that will combine together to say, how do we look after the residents of Shropshire in a more integrated and coordinated way, which absolutely will be to their best outcomes and their best interests, and will make sure that we get services in the right place at the right time. We've got more to do. This is not solved, it's not fixed. I'm not sitting here and saying that is the case, but I did want to recognise the work and recognise the visibility of this and the importance of this as part of supporting the work that we do taking it forwards. So didn't mean that to be quite such a response from me, but just thought it was really important that we robustly and in the right way receive this here. But open that up to Nigel.
Probably repeat a couple of points if I may, but just and obviously for Health Watch colleagues, then this is really vital information, and so it's important. I know Simon said that, but genuinely, and I know you've also with your team, small but perfectly formed, done work specifically focused in whether it be the emergency department or others, and I think that's always really valuable. I suppose I would just perhaps reiterate the point that colleagues have made. We're seeing some of these challenges absolutely across the UK, and hence why nationally there's a delivery plan for the improvements of urgent and emergency care, and that includes all of the different services we've got across the health and care system, because again it's multidisciplinary. I think I won't repeat the points that are included in there, nor necessarily that point that you succinctly made, Lynn, about the sort of three key areas. I think perhaps I'd just reiterate there are immediate, short and longer term actions that we need to be doing. Simon mentioned the local care transformation programme as well as the hospital transformation programme. Those are two core ones with short and longer term. I think the other bit is kind of a bit of a theme, really, isn't it? None of this we're going to sort out with one or either different, different service within the system. You mentioned virtual ward, fantastic opportunity working together, especially the Shropshire Community Trust and SATH. But Patricia and her teams wouldn't be able to do it on her own, but nor would SATH on the. It has to be a marriage, and actually we're already involving both primary care and other people in that. The same really with the discharge. I remember a few years ago in terms of the how integrated discharge, we were one of the first counties actually to really have that in place, and of course therefore we've got solid foundations to continue to build it on. But the multidisciplinary approach, no others have said it, absolutely the way to go on this complex and multifaceted area. Thank you.
Good. I can't see any other. Oh, sorry.
I just wondered if I could just take the opportunity to just expand on one of the points that Lynn made about the falls work. So as Lynn said, she presented at SHIP, and then some very directive action came from SHIP on the result of that, which was really positive, because when the system did receive some money to deal with falls in particular, we were ready to go with it as a collective group. But we also addressed with that, we didn't just look at the falls from a picking up and from a response point of view, but we looked at it from a prevention point of view as well. So what could we do more as a system to really prevent, because falls are preventable, not all falls, but many. So what can we do as a system? How can we support our population to take up what they need to do? How can they support themselves? How can we, when somebody's fallen or they've become aware in our system, whether it's the GP or someone else, that somebody's fallen but maybe not hurt themselves, how can we make sure that doesn't happen again? And then when they do fall, what could be in place if somebody isn't injured to the level that they need conveying? Who could go and help them other than the ambulance service? And the work has been really, Vanessa Watley has led that work from the ICB. It's been fantastic to be part of, and we're looking forward to seeing kind of the evaluation of that work. But I think we can do a lot more in that space, and really looking forward to doing more work with Vanessa on that, because I think across all of our services, we can make something different happen there with not a lot of extra input. I think we've got it. We just need to connect it better.
Yeah. So really helpful, Penny. And look, there's a few bits in here for me, which is great. So Stuart, in terms of police, we need to make sure the Health and Wellbeing Board has a conversation around drugs, alcohol, behaviour, and it links to the integration piece. But we missed the fire service. I would suggest in terms of this, because I'm not saying I recognise they're not the full solution in terms of that, but actually part of how they work as part of the system is really important in terms of that offer. And so I think we probably need to pick up an action actually in terms of how do we engage with the fire service and make sure they're visible and in these conversations as well. Now, there are a couple of hands that went up at that point. I can see some people smiling at it. So, Rich, did you real hand up?
Yes. Yeah, just on the fire service comment, I think we're smiling because we certainly when we said we wanted to have a workshop after the next session around prevent, we see that fire service absolutely being critical in that and want to invite them. So having that conversation ahead and maybe think about their role more widely in the Health and Wellbeing Board would be fantastic. The vaccination programme, or Sherman and Dave will talk about that another time, but these are really positive things that we work with. Sense fire, so we'll come back to that. So I think that'll be really welcome. I guess firstly, just to reiterate the thanks around the report, how hard hitting it is, but really important that we hear the voice of our residents in everything that we do. And thanks for pulling it back together. I think it's absolutely fundamental. I want to reference just some work that our members have been doing as well, because obviously our members are really passionate in this space and have the HASC and Joint Health Wellbeing Scrutiny Committee, as well as our own Health Wellbeing Scrutiny Committee, have had a task and finish group looking at some of this work, looking at that approach. It comes back to the comments that this isn't for one person or one organisation to sort it system wide. It starts and theme again, prevention. What can we do in our communities to support people? It talks about the whole system. Where's primary care in this? How do we all work together? And I think there's some really important findings in that work that will be helpful for us to look at as well. So I think that general commitment, because we know how important this is to the people of Shropshire, but also that preventative approach, that wider integration approach, the themes are coming together. So I think it's helpful to reiterate that paper that I know that they've also been involved in, because a lot of, and that links back to some of the false work that was identified through that as well.
Lynn, you're now using it as a transporter because you've got flashing green.
Oh, I know, I was going to be disappearing into the ether. So just a couple of points from me. One, thank you for your comments on this report. We will be including those in our annual report, so thank you for that. Hopefully they've been noted. That'd be great. The other thing to say is that one of the things that happened for the first time in this piece of work was we were very much supported by YMAS with this piece of work. They were very keen for us to do it and bring that patient and public voice to the table. And Mark Doherty was very helpful in that respect, but also provided the YMAS response to us. And that hasn't always been the case. Because, for example, we've asked previously about the challenges they might have with finding people in our rural communities when there's such a broad postcode, and we've never got a response to that question. I'm sure that people know in this room how they manage with that, because we were hearing from people that it was taking longer because they couldn't find them. But I'm hoping that there's measures in place to try to improve that. It's also fair to say we're continuing to get comments about ambulances. And I think we're at risk as well now that people might be being resistant to phoning ambulances because they're assuming it's not going to come. And we've heard those comments particularly from Ludlow. I mean, I can give you one very flippant remark saying, rather than phone for an ambulance, you may as well phone a funeral director. So I do think there's a communication piece to be done about the availability of ambulances and the fact that if you call one, you will get one. But also, as you've seen in my front paper for this report, for me, it's about this system checking that all these things are working in the way that they need to, but also we don't want to do this piece of work next winter and have exactly the same outcome. So that's all I wanted to say.
Really helpful, Lynn. Thank you. So the Health and Wellbeing Board has asked to note the contents of the report, which I think we've done, note the responses from partners and ask for their support in holding system partners to account for the work they told us they are doing to address the issue of ambulance delays and its impact. So I think hopefully you've had a response to that, and I think the work that is taking place already in this area is really comprehensive, but we need to make sure that that addresses the points that residents are saying to us, not just the process bits that we'll do. So that's where that added value bit comes from. So thank you for that. Okay, moving into a different part of the agenda, which is reports for approval and recommendations. We've got 25 minutes left in terms of meeting time, and we've still got quite a bit to get through. So this is where we're moving to a point of, by exception, with discussion with discussion by exception, but we're approval of the recommendations going forward. So I'm going to go through these at some pace, unless people bring things up where we need to just focus those conversations separately. Joint forward plan update. Claire, the paper's there. You've joined us. Anything by exception that you want to flag, and then anything by exception that colleagues want to highlight on this? Soon to be beamed to we'll think of suggestions.
Yeah. We try another one. The other one, was it because they might work for it?
Oh, put your light off. That's it. Now do it. That's it.
I'm now red. It's all good.
IT support. Turn it off, then turn it on again.
Yes, absolutely. Thank you, Simon. I'm not going to say too much. The paper just sets out the timeline for the joint forward plan, and you've got a draft of 109 pages, which is too long, and there's not enough how in there. And we've actually already done quite a lot of editing, which is going to the planning group this Friday. It's back down to 54 pages now, with a lot more of a how in it, and we'll be working on it over the coming months. Probably worth just saying as well, we're continuing the engagement piece, which is why the summary is included in that as well. So it's going to be a constantly iterative process, and just to say thank you to colleagues, because it has been truly collaborative, and everybody's really made a really huge contribution. We have got some gaps, and we'll be working on those with colleagues as well. So that's all I was going to say, unless there's any comments.
Any comments by exception in terms of that update? No. Okay, so I'm going to thank you for that. We are asked to note the board and accept the contents of the report, recognising its work in progress. Health and wellbeing was obviously we want to stay close to the continued production and development of it, and then do and so what's this going to deliver for the residents of Shropshire. Thank you for that. Shropshire Integrated Place Partnership update, including the Better Care Fund update. I'm coming to Laura Penny, who's making this up.
Do you want to start, and then I'll talk about something?
Okay, yeah. Okay, just very quickly, the board highlight, or the paper highlights the planning guidance. It highlights the slight change, 2-year plan instead of a 1-year plan, which is welcome. It also highlights shift to, it highlights a focus on adults from a national directive, which I think is something that we as a system need to pick up outside of here as a planning, because our previous Better Care Funds included children and young people, particularly around prevention and CAMS. And it also asks for, we have a tight time, as we always do, to put the plan together and to deliver it, but it has to be agreed by the Health and Wellbeing Board. So we are asking for delegated authority for the position of Tanya Miles and Gareth Robinson. I think, and I'm not, I suppose it's just to double check that you are the right positions for the delegated authority.
Laura, did you want to add to that?
Yeah, just to really add that I think, you know, we're just nearly finally reviewing the last year's plan. I think this next 2-year plan needs quite a lot of change, if I'm honest. I think it's been quite historic in terms of where it's been set up. I think discussions today have just highlighted exactly what we want to do next. So whilst there is that eligibility criteria nationally that we've got to, you know, we've obviously got to, you know, submit the application against. There's also what's the strategy and what are we doing? So the prevention discussions this morning, thinking about how do we, you know, do this real admission avoidance, how do we link in the local care plan? We're doing some transformation work around the market and how that all interlinks. So there's a bit of mapping work that we've got to do against that. And it might be that we say, do you know what, there are other schemes that probably will fit better within the Better Care Fund that we're funding. So I know there's no additional money, so I know that, but then there are additional things being funded elsewhere that probably fit far better in the Better Care Fund. So those conversations need to be had next and quite at pace. But I think it's really timely and there's a really good opportunity. And I think all discussions this morning have really kind of highlighted that, particularly the work Claire you're doing with Forward Plan, and obviously the prevention work and some of the commissioning plans that we're trying to pull together at the moment. I think that was it. And it's interesting, if I put a bet on it, I would have said Falls. I told everybody Falls was going to be in the metrics, and they are. So there we go. But so we've got to fit that in.
What the lottery numbers are.
I'll keep them secret.
The street centre Campton this afternoon, that would also be helpful. So, Laura, I think you touched on it. I've got Nigel wants to put his hand up, but I agree in terms of the changes required, and we do that in partnership in the right way to make sure that Better Care Fund focuses on the priority areas of the integration agenda, the discharge agenda, the falls piece, making sure that we get to a much better place around how the visibility of the use of the fund to drive and underpin integration that makes a difference for the residents of Shropshire, and our commitment around this table to do those conversations at pace properly to make sure that there's a really clear understanding, because what we can't do is have delegated authority for sign off and then people come back and say, well, you know what, we signed it off, but I don't agree with what it says. So I think delegated authority is fine, as well, it would be a committee decision as to whether delegated authority is fine, as long as there's a commitment to make sure that delegated authority is done with the get to the right place with the Better Care Fund to then make sure that can be exercised in the right way. Nigel. Yes.
Yeah, so probably just repeat, and I had a really useful 2-minute catch up with Laura just before this. I think there's a couple of offers, if I may, Simon, and a proposal. I think the work, and particularly probably, but albeit parochially, Patricia's teams and SAF have done on a number of different specific areas around virtual ward, but perhaps under the auspices of the local care transformation programme. Have been done with a short and medium term capacity and demand analysis linked to then beds, money, etc. So I think there's some real value, Laura, that we can bring combining some of that work that's been done. But actually, the more important bit is your point about then how we align it to where the priorities of BCF are, accepting they're going to be broader than just some elements there. So I think I would really ask for something that we do together with a handful of partners in the way that you've just described, because I think it's vital to make sure that we've got everyone involved. But I think we can genuinely bring some information, analysis and work that we've been done. I think the second one is I think if that sign off, and it's obviously your call, Simon, but I think Patricia may wish to comment, but I think the chief execs have obviously as a system, not health, have been doing a lot of work over looking at this year's plan and into the next year. So I think something needs to go to the chief execs if as a proxy for if we haven't got the next board. And I think that the other one is, and probably with that capacity and demand bit, and again you'll be doing this anyway more broadly, I'm sure, but and I appreciate I'm probably looking at the discharge elements as opposed to the broader parts of BCF, because there's loads. But I think we really would be worthwhile properly sharing some of those metrics and trajectories, because I think some of that will be really important for us all to join forces on. We've done a lot of work, just been talking about a lot of emergency care type stuff, and reinforce the fact that no one partner on their own can do this. And I think there's a sharing, because I think it would be good visibility, but sharing to make sure that everyone's got skin in the game.
Yeah, thank you. Patricia?
Yeah, I completely agree, and completely agree with Laura's points around now is absolutely the right time to relook at the BCF and make sure that it's aligned to the right priorities that we've got. So it's really focused on prevention. It's really focused on supporting population health and keeping people well and out of hospital as well, and supporting them in the best way. I think doing that. So I think delegated, as you say, Simon, delegated authorities is great. But I think we need to know the where and the how that we're going to do that work, so it's open and transparent, and we can sign that off in the full knowledge that everybody is supported and inputted into that. Point one. Point two, we also have to recognise that for both health and social care, there are some core services that are supported in terms of the funding around that, and therefore if we're going to change it, we need to be aware of what the implications are. That's not by no means saying let's not do the review. I think we should, but we need to understand how those core services are contributing to the overall benefit in the system. So I think it's about the open and transparent, who's going to do it, and which group is going to take the action card for doing that kind of review, so that we get to a programme of work that fits the objectives of this Health and Wellbeing Board and the overall ICS priorities as well. And yeah, I think the sign off and the sight by the system chief executives in owning that, then I think would be really important as well, so that we can crack on and start delivering it, I guess. We don't want to spend too much time weighing the pig, though. That would be my only comment.
I agree with that wholeheartedly. Laura, Penny. Tammy, sorry.
Just to add one final comment to reassure all board members, there has been a system-wide working group across the system for the last 6 months or so, with representations from ShopCon, SAF, the ICB and the local authority, just thinking about what that review needs to look like. So there's lots of, we've got a great understanding now of the current Better Care Fund and what it's delivering, but also an idea about what we want this next 2 years to deliver. What I would ask all system partners is to just make sure that those people understand the timeliness now of getting the submission in, and to please commit to the meetings that we're going to be scheduling, because we're going to have to work at pace, because these dates are not changeable.
Yeah.
Would be my kind of ask, please.
So really helpful, Tony, because I was going to pull that out anyway, but you've put that much better than I was going to put that. So because the bit I was going to say was, can we make sure we've got the right people in those conversations? Because what we can't afford to happen is that work to do the working group and then come to chief execs and say, well, I wasn't cited on that. Why didn't that happen? Well, actually, that would be on me for not having the right person in the conversation, not on the working group that Laura and Tanya and others are doing. So Nigel, Patricia, Tanya, but we need to make sure that we've got the right people in that space to do that work. Laura, Laura Penny worked in my office in terms of when that comes then to chief execs for the conversation, because I think there's real added value in that visibility, and the fact that people want to talk about it is a good thing. The Better Care Fund's not always been in that space.
I'm delighted. I can't believe it. As soon as you go, yeah, we'll just do it over here, everyone's like, no, I don't think so.
But Tanya's point around the timeframes being national and nationally determined and needs to get that in the right place is important as well. So we are asked to accept the recommendations, recognise the work underway to address the key priorities. I think we have. To note the Better Care Fund planning guidance, we have done. To ask delegated sign-off of the Better Care Fund plan to Executive Director of People and Executive Director of Integrated Care Board, with the detailed plan coming to the July Health and Wellbeing Bill for ratification. I think the caveat we put on that is subject to it being visible to chief execs and presented at assistant chief execs meeting. So I'm checking that. I think people are still saying the delegation's fine, but let's have the chief exec visibility to then enable the delegation to happen. And to delegate sign-off of the year-end return to the Exec Director of People. So this is the 22-23 position for the Better Care Fund to Executive Director of Shropshire Council and of the ICB, and I'm comfortable with those as well, as long as committee members are comfortable with that. Yep, good, really helpful. Thank you for that. So thank you, Penny, thank you, Laura. So Shropshire Family Carer update, all age carer strategy and update. So I'm accepting the recommendations provided unless members indicate otherwise, which is that the board has asked to note the content and support the all-age carer strategy, recognising carers are integral to any planning of services.
Marguerite's on the call.
Oh, Marguerite, sorry, I didn't.
No, you wanted to know.
Apologies, I didn't mean to ignore you on having joined the call.
That's fine.
Does anybody have any comments or anything else? Tanya?
I just fully support this strategy and the recommendation. It has been through to SHIP, who also endorsed the strategy, and the PCNs in Shropshire want to take that one step further and ensure that this is embedded across all of their PCNs across Shropshire. So it's really exciting development.
Okay, it's really, really positive. Good. So thank you for that update. Tanya, Marguerite, thank you for the work on this. And like I say, if we can, the visibility of this coming back in terms of what's the impact and how do we get that and make it real, I think it's really important. Claire, just so I'm about to close this down.
Wasn't specifically about the paper, but just thinking of the stories and things that are happening around the PCNs taking on the carer strategy. Should the Health and Wellbeing Board think about some kind of newsletter or communication that goes out on a regular basis to our public so that they know some of these fantastic things that are coming from the board?
I think that's a really good point, actually, because so I think there's a comms concept. I don't want to be the expert. I'm far be it from me to say it's a newsletter, it's social media, it's this, but I think there's a whole comms conversation piece of how do we talk about the good work that's happening and cascade that and share that. So I think a really good point.
Yeah, so just on that point, I'm part of the Regional Health and Wellbeing Officers Group, and there is one area, can't remember which one it is, that does that health and wellbeing newsletter. So okay.
So let's not lose that action, because I think that's a really important point in terms of we think about the conversations we've had this morning, the discussions we've had, and there's been a lot in that where we should be sharing it and talking about it and talking up the positive work that's taking place. So good. Okay, during strategic needs assessment, drug and alcohol, so Rachel and Alex, I'm intending to accept the recommendations detailed in the section of the report, unless you want to highlight anything separate.
No, I think Paula's going to come in. Jess is online, who's helped pull all of this together as well. But I'll just pass it over to Paul's question.
Paula.
Oh, there we go. I'm on. Yeah, so just the board is presented with the recommendations for the joint strategic needs assessment for substance misuse. I just want to flag a couple of really key points. I think there's a lot in here around integration. Again, it's a real consistent theme that need to kind of join up our substance misuse, our mental health and our domestic abuse services. So there's some strong recommendations in the report around those. Also really want to be mindful of people with substance misuse physical health needs as well, and to not lose sight of those in the mix of focusing on their dependency. There's quite a few recommendations, as you would imagine, around the treatment side. And I guess the other thing that I wanted to flag is we want to have that real focus now moving forward on the harms caused to children and young people if they're living with families where there's somebody who's dependent. So the recommendations are there, how we've come to those recommendations from the data, and what some of our aspirations might be as a system then to move that forward. Obviously, substance misuse has remained a priority group of the Safeguarding Partnership, so the recommendations will be picked up through that group. We will look to refresh the business plan and action plan to move those forward. So it's really presented to the board today to endorse the recommendations.
So happy to endorse. I think if I also think about the work that the Police Fire Crime Commissioner is also doing in terms of the link to antisocial behaviour and how do we get this into the right place, I think there's a future forward planned conversation piece of how do we pull these strands together and talk about actually how are we working in partnership to deliver some of this in a different way. So you know, I'm sure Stuart and others would have input into that conversation as well.
Yeah. We have really good representation from the police on the partnership group. We work really closely with them. And interestingly, Tanya and I met with the PCC's office this morning before we came into this meeting to kind of have to continue those joining up conversations.
Yeah, so we'll build that into the forward plan as well. Yeah. Okay, thank you for that. So board accepts the recommendations as set out in the paper. Reports for information. I am going to go through these at pace. We received two. We received the health protection update and the Armed Forces Covenant updates. So we received two reports. The board has asked to note the contents of the report for information. There were no recommendations that were happy to do that, which is good. So Chair's update, correspondence from NHS England. Oh, sorry, Kirsty.
Now, I just really wanted to highlight some of the comments in the Armed Forces Covenant report, and just actually, you know, again, for the record, can we thank Sean and Sarah and the work they're doing in the veteran community. As a veteran myself and mother of a serving Royal Marine Commando, I cannot tell you how Shropshire are really visionary in what they're doing, and we can never, you know, appreciate the work they're doing within the Armed Forces community for social isolation and just that constant support that they give. So, you know, yes, we note the report, but please can we also note the hard work that's going on continually for our veterans and serving personnel. Thank you.
Well said, Kirsty, and thank you for your service and for your son's continued service. Nigel.
I'll just say the same. I think as former Air Force, and my son's in the Air Force, then I'm on the same page. But I think more than that, I think that the team and the council, you know, as Kirsty's mentioned, do a heck of a lot, and they really help galvanise, you know, the work that we've got on from a field hospital, the Covenant, and all the veteran awareness. We're particularly doing, and I do wonder whether it's something again we can continue to join forces on, is looking at that continued areas of opportunity for employment. I know we've got now a former former military chap in our workforce team, and he's been really pushing on that. But again, it's a real opportunity to join forces. I think there's the plan, isn't it? Join forces, but join together on that because there's real opportunities. So,
yeah, and as the ICB, I'm working with Sean because we'll have to refresh and update our signature to the covenant because it was the CCG previously and the new statutory organisation. So I'm working with Sean that we do that and make sure that the ICB's signed and committed in that space as well. Good. Okay. Thank you for that, and recognise that the health protection update was in there as well. So I was just about to get into closing comments. We have had correspondence from NHS England about changes of pharmacy operator and ownership. So Hills Pharmacy in Churchside is now operated by Gill and Nagra Limited. Lloyd's Pharmacy in Ludlow is also now owned and operated by Gill and Nagra Limited. And supplementary opening hours for Murray's Healthcare, Market Drayton, from 40 hours per week to 49.15 hours per week. And Boots Pharmacy at Mitten Oak Road, opening hours are increased from 40 to 44 hours per week. A summary of that update will be placed on the council website. Equally, Director of Public Health's annual report is currently being drafted and will be brought to either the June or September board meeting. And we'll get an update on that in more detail, and then the prevention board will cease to be a separate board as its work will be included under the Health and Wellbeing Board's health protection update. And then a date for your diaries, Monday the 19th of June, Health and Wellbeing Board and the SHIP workshop, joint workshop. Holder date's been sent. If people can protect that in their diaries, really important that we have that joint conversation between the Health and Wellbeing Board and SHIP in terms of the work across the two. And Rachel's indicating that she wants to come in on something that I've missed.
No, just before you close the meeting, there is one important item that I just thought it was.
I'm coming to that.
Before we turn down.
I wasn't going to turn it off. Got it in hand.
Sorry.
And which I'm going to do. Everybody's now thinking, what's this big building? What's going to happen? Like, we've waited for all of this time.
Double act.
So I think this is probably the most important part of the. Actually, it's been a really important agenda, and there's been a really good conversation, really good discussion. But part of that is driven by the energy and the enthusiasm that people bring to bringing the Health and Wellbeing Board to life and the agenda items to life. So thank you to each and every one of you for your contributions in this. But there's one person who's been an absolute driving force in terms of the Health and Wellbeing Board and bringing some of this agenda to life. And you heard that individual talk about the first agenda item that we talked about in detail. But that person, Val, who's sitting to my left, I've worked with her much less than many of you, but she's an absolute star. But she's also retiring, and this is her last meeting. And so it was absolutely appropriate and important that the Health and Wellbeing Board, while streaming to the public and whilst everybody else is still on, had the opportunity to say thank you, to recognise your service. If you look to your left. So what everybody doesn't see is, as I look at my screen here, I've got an annotated agenda. I've got a set of notes in terms of Chair's notes for me to make sure I don't miss anything. Claire's looking and nodding and saying, I'm saying, why doesn't this happen in the ICB? I've got the normal agenda, there's prep calls, and all of that is predominantly driven by Val in terms of the hard work that happens to make sure that the meeting runs so that we get into the right level of conversation in here, which I think this morning is a real prime example of, because we've had really good conversations, but that only happens because of the work that happens behind the scenes. So I really wanted to make sure that we took the opportunity as a board, co-chair with Councillor Motley, to say thank you to you. Look, there's a lot more that you do rather than the Health and Wellbeing Board. There's a lot more that you do in terms of for the council and for local people, but in public, for the minutes, for the record, I wanted to put, as co-chair with Councillor Motley, our thanks from the Health and Wellbeing Board for everything that you've done, and wish you all the best for your retirement.
Thank you very
Rachel,
much.
Rachel,
Thank you very much. That's really touching. Thank you. I really appreciate that, and I do love my job, and I'm going to be so sad to leave, but it's the right time. Without boring you, I'm going to need to see my mum who lives up north. I need to run and get rid of my belly. I want to do marathon fit again because that's what I love doing. So yeah, that's my plans. So thank you. You're brilliant. take it forward. Yeah, thank you.
Rachel, anything anybody else wants to say?
I mean, we'll have some opportunity later today and then next week and we'll not get upset at this point in public. We'll get upset with you. But just a massive thanks. I've been here 4 years. You've been in Shropshire much longer than I have, serving the community and serving the council and serving health before you. And we were discussing this, weren't there? There's various places that you've worked, but your contribution is immense. Your passion came through in leaps and bounds today, but through everything that you do, and you will be absolutely missed. And just thank you for everything.
I'll miss everybody. I'll be around. I'll hold you.
Cecilia, you've got your hand up.
Yeah, I just wanted to say, Val, that bearing in mind you've had to deal with rather a lot of representatives from Shropshire Council over the last couple of years, and chairs indeed over the last couple of years, I would just like to say that you have really steered us quite brilliantly. You inspire confidence in us because we know we're not going to go too far wrong because of all the wonderful information that you give us in order to conduct the meeting. So I would just like to thank you so much. And I have to say that I'm extremely sad that you've decided to go running instead of staying with us. But I do respect your decision, and I wish you a very, very happy retirement.
Thank you.
Thank you, Councillor. On that note, I think we've had a really successful morning meeting. And also, with your help and your contribution, we've managed to bring it in at 12:01, which is really appreciated. So thank you to everybody for that. We did start 2 minutes late, so I'll work on it. Actually, I'm finishing 1 minute early. I think we are done. Really great. Date of the next meeting is on the agenda and is in diaries anyway. Thanks everybody for your contributions this morning. And Michelle, if you could let us know when we finish streaming, that would be great.